Hi guys, welcome back. The topic we're going to study now is chronic kidney disease. In the first 5 minutes, I'll be explaining to you various methods available for GFR calculation, a couple of equations. Then I'll explain to you the cutoff. I mean, below what particular value or set of values would you be saying that person is having a chronic kidney disease? And more importantly, you see GFR tends to vary with age. Usually by the third decade of life, the GFR of a person would hit about 120 to 125 ml per minute value, and then it begins to reduce. The reduction is approximately 1 ml per minute per year. So by the time a person is 70 years of age, the GFR tends to decrease down to 70 ml per minute. So the message is that GFR is not constant all through our age. I mean, it varies with age. It also varies with gender because serum creatinine is dependent on muscle mass, and women will be having a less muscle mass. So therefore, serum creatinine values for men and women for the same age group will also vary. And I can then say that even race would matter because we Indians are more predisposed to development of obesity. If I compare ourselves with Russians or with blacks or Europeans, they tend to be relatively more muscular, and therefore the serum creatinine values will be dependent on three parameters that I mentioned: race, age, and gender. And with this background information, let's just jot down the various methods that are available for calculation of glomerular filtration rate. You see, from a physiology standard point of view, I can say that every time you attend a physiology class in first year, they always teach us that the best method for calculation of GFR is inulin clearance. But if you want to call any laboratory, suppose Lal Path Lab, you call up and you say, I want to get an inulin clearance done. Most of the time, they'll just say, sir, they hang up the call and say, sir, we don't have this facility available. So, I mean, this would be more from an academic standpoint of view, or some research institutions would be doing it. So I agree from a physiology perspective that if they give you a question where you have options like inulin clearance, then PAH clearance, and then urea clearance, and they ask you to select one, then you obviously will enter inulin clearance, where you will have to collect 24-hour urine of a person. But this is more from a physiology perspective. So how would you in your hospital determine glomerular filtration rate? Another method, in fact, which is available, I mean, what the lab will say is alternatively, okay doctor, what we can do for you is a creatinine clearance. And well, the problem with creatinine clearance is that you need a 24-hour urine sample or a urine collection. And I can say that that would be cumbersome because of under collection or over collection. And then they'll measure the creatinine values in the urine sample of the patient provided, as well as they'll take a blood sample of the patient, and then based on the 24-hour urine amount, a statistical formula will be used to arrive at creatinine clearance of a patient. But over and above these, we have a couple of equations available where, on the basis of serum creatinine value, age, gender, race incorporated, we can determine the GFR of a patient. So problem with test number 4 is simply that it does not incorporate age, gender, and race issues which are highlighted before you. It does not incorporate what I was telling you. The GFR tends to decrease by 1 ml per minute every year from, let me say, 25, 30 years onwards till the age of 70 years. So another equation that you should be aware of, and this is what I used to study when I was a student your age, was Cockcroft-Gault formula or Cockcroft-Gault equation. I'll write down the formula before you as well, just to make you more comfortable, though in the exam it's unlikely that they'll make you remember the formulas per se, because the first two that I'm going to tell you are the more sophisticated ones. They have complex mathematical equation. It's unlikely, it's not a mathematical exam, so they're never gonna give you an equation and say, okay, this equation would stand for, at least historically in last 20 years, they never put up a question like this. So in your exam, what he's gonna say is, what is the best method or equation available for calculation of GFR? Then your answer would be CKD EPI equation. Now, this equation has an advantage because it incorporates all the three parameters that I was talking about. I mean, it takes into consideration age of an individual, race of an individual, and gender. It's there are a lot of medical apps available nowadays, and you can just in the drop-down menu enter the age, race, gender, serum creatinine values of a person, and then on the basis of that statistical formula, it will give you estimated glomerular filtration rate. Yeah, while listening to me, if you Google the word CKD EPI equation, there is a possibility that couple of apps might actually be displaying CKD EPI cystatin C equation. I don't dispute that. I mean, that's also a good one. It's just that in Harrison is mentioned CKD EPI equation, but sometimes you might incorporate this word CKD EPI cystatin C. Well, as doctors, we are always trying to better ourselves. We are always looking at more accurate methods for calculation of estimated GFR of an individual. So there is a method available, cystatin C. I mean, where is cystatin C coming from? Then cystatin C is produced by all the nucleated cells and it is in a steady state in our body. So, I mean, more parameters, if you keep on adding to the statistical formula, you should be able to arrive at a more finite and a more accurate GFR values of an individual. The second equation name, I'll first mention the short form of it, that is MDRD. That is, okay, let me just write it down. MDRD, it would stand for modification of diet in renal disease formula. MDRD or modification of diet in renal disease formula is also mentioned in the current edition of Harrison. So though I have written the data in decreasing order of importance, in a sense that if you get a question and they ask you to calculate best method for calculation of GFR, then CKD EPI equation. I mean, this was published in 2021, the CKD EPI equation, and then cystatin C came up. These would be the best methods by which you can determine the GFR of an individual. At this junction, I also want to tell you that in CKD, there is a lot of catabolism occurring in the body. Because of this catabolism, there would be muscle wasting. And because of this muscle wasting, serum creatinine can be falsely normal. You see, somebody has a serum creatinine of 2 milligrams, 4 milligrams, gross elevations, understandable. But in CKD, there's a possibility that his GFR is less, but his serum creatinine can be falsely normal. Why? Because of the catabolism process that would be occurring in the body of these patients. Now, before we go forwards, let me just use this opportunity to also mention regarding the Cockcroft formula or equation before you. This would be relatively simpler. The formula goes like this: 140 minus age. This is to be multiplied by the weight of an individual, and in the denominator, this would be 72 into serum creatinine. Whatever value that you will get here, like suppose you get a value of y, then you have to multiply this by 0.85 in case the person or the patient of yours, the gender of the patient is a female. So the advantage of Cockcroft formula is that it is superior to, I can say, creatinine clearance, because at least it is taking into consideration the gender of an individual, but it is not taking into consideration race. The formulas that incorporate even the race of an individual are what I have explained to you in point number 1 and point number 2. And one reason why I mentioned this equation before you is simply because in the exam, they gave a, this was in the INISET exam, they asked you to calculate GFR from a pediatric domain. Now, I'm sure that you would have studied regarding the formulas for calculation GFR from the pediatric perspective also. But since the question has been asked in the exam, what I'll do here is, just share that question before you, and while you read it, I want to tell you that when it comes to pediatric age group, it is not the weight, but it is the height of an individual which is to be considered in the formula. Now let me just put up this formula which you read as Schwartz formula. When it comes to the Schwartz formula, I repeat once again, it is not going to be the weight, which is a deliberate distraction, because a lot of people started using Cockcroft formula for this particular question and they got it wrong. So in the Schwartz formula for calculation GFR, you have to take into height. Then there's a kappa or a constant value. I'll tell you the mathematical incorporation for kappa as well. And in the denominator, you need to put serum creatinine. You see in the exam, whenever they give you a mathematical question, it will always either be a one-step multiplication or a one-step division. So here the height of an individual is 100. The kappa value to be taken is 0.41 or 0.40 approximately. Serum creatinine is 1. So you have the answer before you. The GFR of the patient is 40 ml per minute. And that does not indicate that it is lesser, because we are talking about a kid at the moment. And as you can see, I'll reiterate that statement that most of these, I would say, mathematical based questions that are asked in the exam, they don't give you a paper or a pencil, are either a one-step multiplication or a one-step division. Now, once you have got an idea regarding the methods available for calculation of glomerular filtration rate, I would also like to mention that there are a couple of tests available by which we can even identify acute kidney injury. You see, though I've discussed it separately in acute kidney injury topic, but I want to use this opportunity at the moment that acute kidney injury will evolve over 6 to 24 hours. So if I tell somebody like your dad has suffered from renal injury after, let me say, his dad had a MI, And then he went into cardiogenic shock, and then cardiogenic shock can cause a ischemic damage to the tubules, and he went into acute kidney injury. I mean, about 30% of our ICU admissions are complicated by acute kidney injury. I'm not saying that 30% of ICU patients are suffering from. I'm saying 30% of admissions are complicated. They might be admitted for some other reason, but they ultimately end up with development of multi-organ failure, and one of the organs that is damaged is the kidney. So we need to also simultaneously quickly revise regarding the biomarkers of acute kidney injury. So I'll use this opportunity to mention at least three before you. One of them is NGAL. Just like we are studying that for chronic kidney disease, we need to calculate the GFR accurately. I'm going to tell you the KDIGO classification soon, but I'm just deviating slightly from the topic to sensitize you to the fact that in acute kidney injury, why should I wait for 24 hours or for that matter of 12 hours to diagnose that the kidney has suffered a damage? I should be able to do a test in the urine sample or plasma and determine the damage relatively early. You see, medical science is all about early diagnosis. Just like in myocardial infarction topic, I've explained that, troponin is the routine test that we do, troponin I or troponin T, but we also have a heart fatty acid binding protein available, which can become elevated in as early as 1 hour. So the message here is that we would like for early diagnosis, that is neutrophil gelatinase. Because of a tongue twisted name, there is a high probability that this can be asked. Neutrophil gelatinase associated lipocalcin. Why you should know this is because first time when you read this name, no neutrophil word coming up, you think something related to immunity. And surprisingly, this test that I'm telling you is a urine test, or we can test it in the plasma. It helps you with early identification of a kidney injury. Point number two that I'll say before you are, most people when they are encountered with KIM1, they're able to answer it either by guesswork or because they've read it. You are brilliant chaps anyway. So KIM1 would be kidney injury molecule. This is relatively easy for anyone to guess and answer, and therefore we have now kits available. Obviously in research institutions where urine and plasma KIM1 values can be checked. The next one that I'm telling you again has a slightly peculiar name. It's written as SUPAR. So let's just use this opportunity. This test would be available as a blood test only. For SUPAR, the older edition I was mentioning interleukin 18, this edition I'm mentioning SUPAR. So this would be standing for, because short forms, it's always a good idea to remember them. So this would be a soluble urokinase plasminogen activator receptor. I repeat once again, SUPAR would be a soluble urokinase plasminogen activator receptor. And this again not tested in the urine, it's tested in the blood. But this again gives us an idea regarding that, yes, there is a damage to the kidney, and lots of cases of CKD can actually be having a subsequent AKI superimposed on a chronic kidney disease. A person like, let's assume somebody is having diabetic nephropathy. He is already suffering from chronic kidney disease. Number one reason for chronic kidney disease is going to be diabetic nephropathy. And if this person suffers from diarrhea, or suffers from bout of food poisoning, develops vomiting, then there would be volume depletion in the patient. And because they have a low renal reserve, any person with a low renal reserve has, and the kidney is already damaged, there is a higher chances of these patients developing acute kidney injury as compared to individual who has a normal renal reserve. So for early identification, I mentioned a couple of tests here before you. I mentioned these various formulas also, like the CKD API equation 2021 is what is mentioned in the current edition of Harrison. And these are a couple of statistical formulas which you can see. I'm currently zooming into the slide. It's not practically possible for anybody to cram the data up and then remember all the multiplication factors here. Look at it, raised to power minus 1.200. It's very unlikely that they'll make you calculate. They give you a formula and then they ask you, and they never have in historical perspective. So I just thought I'll just show you this slide, because the older books used to talk about MDRD and used to talk about the Cockroach-Gold formula. Now, once we get this in the right perspective, next we're going to study regarding how GFR will fall gradually and what are the stages of chronic kidney disease. Now, focusing on the GFR categories, we'll divide this into G1 to G5. Glomerular filtration rate, if it is more than 90 ml per minute, 1.73, that would be standard data all the time, 1.73 meters square of body surface area. Then this category would be called as a normal or a high GFR value. High GFR for, let me say, a 70-year-old man, because I said 70, the GFR would be as less as 70 ml per minute. But once the GFR tends to reduce and we go into G2, that's when problems would start occurring in a person. So I'll next describe the category as mildly decrease, and you need to decrease, you need to subtract 30 from it. That is, if the GFR of a person is in a range of 60 to 89 ml per minute, the remaining data remains the same, then you will say that there is a mild decrease in the glomerular filtration rate of an individual. On the other hand, if using the equations that I explained to you, you decrease the GFR even further. So this time the decrease would be again in 30 points. And by 30 points, I mean 30 to 59 ml. Then I'll say this would be G3, which has been subdivided into 3A and 3B. For technical reasons, you'll understand the concept behind it in few seconds from now, why it has been subdivided into 3A and 3B. But now the mathematical trick is that don't decrease by value 30. Look at the mathematical values, 90, 60, 30, right? That was the lower limit. So now we'll incorporate stage 3A. So a bit of mathematics here coming in. That is from 60, I'm decreasing by 15. So 60 minus 15 would be 45. So 40 to 59. On the other hand, if you have a value given between 30 to 44, that would be 3B. And why this has been done is they have subdivided this mainly to say that if it is 3A, then you will say it is mild to moderate decrease. Whereas if it's going to be between 30 to 44, you will say this is moderate to a severe decrease in the GFR of an individual. And why are we making life so difficult for ourselves by getting into these mathematical aspects is mainly to sensitize you to the fact that if the GFR of a person, the older definition, which I'm now going to quote here is that when I was a student your age, I used to study GFR less than 60 ml per minute, 1.73 meter square body surface area consecutively for 3 months is categorized as CKD. This was the older definition of chronic kidney disease per se. I'll repeat that once again. This was an older definition that GFR of an individual is less than 60 ml per minute for 3 consecutive months. Agreed that you need to serially follow up the patient to say that this is a chronic process. But because of the fact that this 60 value, as doctors, our objective is early diagnosis. So he says that why should you wait for the GFR to decrease from, let me say, 120 to 60, that is 50%. And then you say, okay, man, you have a CKD. Why would you not like to pick up a patient who's having, let me say, a GFR of 75 or 80 or 85? So early identification is the reason why these categories have been created. So the older, it's not that old definition is wrong. Our objective as a doctor is just to increase our sensitivity with respect to early diagnosis in a patient. That's why we are having categorization like a mild decrease, mild to moderate, and then a severe decrease. And now we are gonna reach an important value. And the importance of this value is that if no decision is taken at this point of time, then person will subsequently land up into uremia. So let me just write down G5 before you. At this grade, at this stage, the glomerular filtration rate of the patient would be less than 15 ml per minute. The earlier term that was used for this was end-stage kidney disease or end-stage renal disease. Now, the problem with this terminology is when you tell a relative that, your dad is suffering from end-stage kidney disease or end-stage renal disease, it's a very depressing kind of a term. So currently what he has done is, and I'm deliberately erasing this now, instead of writing the word end-stage renal disease, which he says is a very emotionally depressing term, he has replaced this with the term renal failure. So at the moment, I'll write both the terms so that you can understand the gravity of the situation. My patient is having end-stage renal disease. I'm deliberately avoiding to say that term in front of the patient, the depressing term. I'm using the word renal failure. But this is the time when uremia ensues. This is the time when hyperkalemia will set in, metabolic acidosis will be severe, encephalopathy will set in, uremic pericarditis will set in. His breath will be smelling of urine, uremic fever. You need to do a hemodialysis in this patient if he lands up in the stage of uremia, that is end-stage renal disease or end-stage kidney disease, which is currently called as renal failure. The importance of knowing this is that I would not like to breach this barrier. I would like to take a decision even before a person's GFR hits a value of less than 15, that is right in G4. The value for G4 that you need to remember is value between 15 to 29 ml. That is, if you look at it from the mathematical perspective, just look at the mathematical. I know that initially, remembering this table will be difficult. So try to focus on number 90, 60, 30. That is 30 degrees. And then you have decreased from 30. The decrement is only in 15, right? From 30, you're downgrading to only 15, no? So a bit of practice and you would be done with this data. I said 90, 60, 30. Just remember these numbers: 90, then 60, then 30, then 15. Because the decrement then is occurring in intervals of 15. So the GFR of a person is between 15 to 29 ml. You are going to call it G4. And this is the time when education of the patient, informed consent should be taken with respect to the fact that, sir, you can deteriorate and we need to take a decision now of renal replacement therapy. By renal replacement therapy, I mean either we plan a dialysis or we can go for a allogenic kidney transplantation. But depending on, some people would never have economic support. I mean, kidney transplantation in a private setup can cost up to 40 lakh rupees. A lot of people may not have that kind of a money, financial muscle power to get procedure done, or donor may not be available. So depending on various circumstances, I'm saying best is obviously a allogenic kidney transplantation. If not available, I'll have to do a hemodialysis in the patient. With one session of hemodialysis is for 4 hours approximately, and has to be done 3 times per week. So approximately 12 hours per week this person would be spending in a hospital getting his blood cleaned of the uremic toxins, and that affects the quality of life. So overall, I can say kidney transplantation is superior and has better results, better quality of life as compared to allogenic kidney transplantation. But the decision for this should be taken in G4, where we will say that the person is having a severe decrease in the glomerular filtration rate, and this is the time when we must go in for a decision making for renal replacement therapy. This is itself a question. I mean, when should you institute renal replacement therapy in a patient of CKD? Then G1, G1, G2, G3, though there are problems even there, but we can manage the patient medically. What I mean by managing the patient medically is you'll have to control hypertension, hypervolemia, hyperkalemia component, then metabolic acidosis component of the patient. So medical management of the patient would be continuing in all the stages. But the time when you need to do a proper decision making, a proper information to the patient about the pros and cons of every procedure, and depending on the convenience and the decision of the patient, we'll proceed with that. But G4 is the time, if we do not intervene, then there is a high probability that the person will go into uremic complication, uremic encephalopathy, might start bleeding into pericardial space, and we can even lose the patient. Now, the importance of this GFR categories is one, that it helps you early identification. Like I told you initially, cutoff of less than 60 for 6 months, but he says, what about patients with 70 or 80 value? I mean, are they not entitled for medical treatment? Yes, they are. Why they are entitled is because when a person is going into G2 stage, that is a mild decrease of GFR, then the RAS system will be activated. The activation of the RAS system, hyperaldosteronism would set in, and therefore high blood pressure will start developing. So lots of times CKD can be initially picked up because the person was being worked up for hypertension. Once he goes into G3, that is one, anemia component will come up. There are multiple reasons why a CKD patient could be having an anemia. It could be chronic anemia of chronic disease. It could be bone marrow fibrosis, production of erythropoietin where the kidney also is reduced. So anemia is going to start occurring, or pallor is going to start occurring at G3, and person would be requiring erythropoietin stimulating agents to be given at this point of time. Also, kidney synthesizes vitamin D3. Because the synthesis of vitamin D3 is less, calcium will be less. And if calcium is less, then hyperparathyroidism of the secondary variety will start occurring in a person. You are aware of this MCQ. Leading cause of primary hyperparathyroidism is parathyroid adenoma. Leading cause of secondary hyperparathyroidism. Leading cause of secondary hyperparathyroidism is the topic that we are studying, chronic kidney disease. The disadvantage at this point of time is that when PTH is increasing, this would also cause an increase in the value of phosphate. At this point, I mean, lots of you who have listened to me in endocrine section will say, sir, how is this possible? You told PTH causes phosphate loss in the urine. I stand by my data. But the point is, PTH causes phosphate loss only when GFR is normal. If somebody's kidney is damaged, then phosphate will not be excreted. Mark my words there, phosphate values are always increased in CKD. Why? Because the GFR of the person is reduced. So if it's not going to get filtered, it will accumulate in the body. Hyperphosphatemia, why it's important? Because it causes calcification of arteries and increases cardiovascular mortality. Guys, if they ask you what is one of the leading causes of death in a person of CKD, then don't answer uremia. I'll repeat that again. If they ask you what is the leading cause of death in any patient of CKD, yes, uremia can occur. Uremic complications will occur. Bleeding can occur. But the number one reason why a CKD patient will die, why a dialysis patient, you have already started dialysis. Still, dialysis also causes exerted atherosclerosis. I'll explain the dialysis process subsequently. But dialysis again predisposes to exerted atherosclerosis. So I said two factors are operating. Hyperphosphatemia because kidney is not working properly. And dialysis per se causes exerted atherosclerosis. So cardiovascular mortality is the number one reason for a person of CKD even when he is on dialysis. Once he goes into G4, that is when acidosis and hyperkalemia component will become severe enough to the level that medical therapy will stop working. I mean, initially, you could be giving oral soda bicarbonate in a person. You could be giving novel potassium binding agents, but now the potassium values will begin to spike and might become resistant to medical therapy. So if he says metabolic acidosis resistant to medical therapy, hyperkalemia resistant to medical therapy, that is when you will have to do a dialysis in the patient. And as I explained, I mean, I don't want to breach this barrier. I want to prevent this barrier from being breached. I don't want a person. All of these complications that I've written will become much more severe in G5. Understandable, no? Because this is a progressive deterioration of the GFR and progressive deterioration of the kidney function in the person. But my point is that because we know that all of these are the stages when these complications are beginning to occur and cardiovascular mortality is increasing, then I would not like to. I've written acidosis, hyperkalemia at G4. It's not that they can't occur in G3B. Yep, mild amount of acidosis and hyperkalemia can be present in G3B as well. It's only that it will be responsive to medical therapy. Once we progress from G4 to G5, I said once you breach that barrier, then it will become refractory to medical therapy. So when you will listen to me speaking about indications for performing hemodialysis in a patient, I will be saying words like metabolic acidosis not responsive to medical therapy, hyperkalemia, volume expansion not responding. I mean, the amount of volume expansion CKD patients could cause pulmonary edema. You given diuretics, max amount of it, still is having pulmonary edema. So you don't have an option then for the excess amount of volume expansion that's occurring in these patients. We need to remove that excess of fluid by doing hemodialysis in these patients. Once you get these values right, remember 90, 60, 30, and then decrease by 15, 15. Then the next aspect, which I want you to remember, I mean, the table will obviously matter, but what I also want you to remember is that simultaneously, we will also be checking out the urinary albumin creatinine ratio. Apart from calculating the GFR of a person by the statistical formulas, you are also supposed to calculate UACR, that is urinary albumin creatinine ratio. I mean, what should be the amount of albumin in the urine of an individual? Then your answer would be that the amount of albumin in urine of an individual should always be less than 30. In the denominator, it is not per day. It is per gram of urinary creatinine. When I say UACR, this is an independent risk factor for development of kidney damage. Lots of time people might be having a negative dipstick, but in spite of having a negative dipstick, their urinary albumin creatinine ratios might be falling into a category that I'm going to describe before you, which is could be he could write 30 to 300 milligram of albumin per gram of urinary. The denominator is per gram of urinary creatinine. For urinary albumin creatinine ratio, you just need a spot sample. Previously, we used to collect a 20 for a urine sample. Under collection, over collection issues can be there. Now he says, what's the hassle? I mean, why to get into that hassle? Take a spot sample and check for urinary albumin and urinary creatinine. And in case you get values like the ones that I'm mentioning, then it means albuminuria is present. For A1, I said A1, then I said normal also. So you will in a few minutes realize that why am I talking about it, the normal variety. Or let me just incorporate this table here. If you look at this table, you can see that A1 category in the table, A1 category, I'll just zoom it in more, has been described as normal to mildly increase. And the couple of green boxes here just to tell you that suppose a person is having a report as, suppose I write person is having G1, A1, so that can be normal also. I mean, age-wise, if I have a younger individual, somebody who's old age, DFR will obviously be reduced. I need to incorporate the age one. But suppose I say person's grading is turning out as G1, A1, that would be normal. But suppose I, just for the sake of discussion, suppose I say that the value of an individual is G3, A1 as of today. And then after 6 months, he deteriorates into G3B. Let me use a different color. And the same person deteriorates into G3BA2. That means a deterioration in the patient. So you can see that there is a progressive color shading present in this KD code table, just to tell you that a person is deteriorating. I mean, all the reds here imply severe amount of damage to the kidney function. And from the exam perspective, what he can ask you is these categories of A1, A2, A3. When I say A1, it is normal to mildly increased. So I'll go back to the data that I was saying. You need to remember 30, 30 to 300, and then values more than 300. Why am I choosing to emphasize method? Normally, I don't do that. No, normally I say forget about values, just focus on concept. But why am I saying that is because in these questions where they'll describe serum creatinine and they'll also describe the urinary albumin creatinine ratio, they can play a trick. And the trick would be simply that they'll change the units. Instead of saying, like I told you 30, normal. And in the MCQ, he will say less than 3. And your query would be, boss, you said less than 30. I mean, 3 is the return. Is it normal or not? I mean, is it not very less, or is it a mistyping? You will notice that lots of time in the denominator, instead of saying gram of urinary creatinine, instead of saying gram of urinary creatinine, he will write the word millimoles of urinary creatinine. So lots of time in multiple choice questions, he would just like to trouble you by changing the units here, which is gonna be 3, then 3 to 30 and more than 30. You can now appreciate why am I emphasizing it, because just a few minutes ago I was telling you less than 30 is normal. Now I'm telling you more than 30 is problematic. Problematic to the level that I'm calling it A3. See guys, if you missed it out, I'll say once again, I told you less than 30 milligram per gram of urinary creatinine. And suppose you are casual while listening to me and you don't take into consideration the unit. So less than 30 is normal. If I say more than 30, then it should turn out to be A2, right? If I say less than 30 is A1 and I say more than 30, then it should be A2. But in the question, it will turn out to be 30 per denominator will be millimole, turn out to be A3. So one, I just want you to be sensitized to the fact, just get this fact right. I mean, mathematical values are secondary. In the question, what you need to see is albumin will be in the numerator. In the denominator, is it gram of urinary creatinine? Is it millimoles of urinary creatinine? If it is going to be grams of urinary creatinine, A3 is going to be more than 300. At least this single value can be remembered, more than 300 for A3. But if he says A3 again, but in the denominator it is millimoles, then your answer would not be 300, it would be 30. So my request to you, I mean, it's not possible to remember the entire table in first go. Agreed to that. But then some values you can remember at the moment, like I was saying, try to remember those values of 90, 60, 30 and 15. That is how you were reducing serially, and then at least get the 330 right, because I get a lot of messages saying, sir, you said 300 and then in the MCQ it is written A3 is more than 30. It's the denominator that is changing, and we use a combination of these. That is, I'll just go back to my slides. We use a combination of these GFR categories, right from G1 to G5, and albumin values to describe that whether the person is improving or is deteriorating. Once he goes into G4, we would not like to breach that line of reaching G5. We should institute education of a patient, explain to him regarding what are the treatment options available, and there would be 2 of them. And if they ask you to select one, then from the survival perspective, quality of life perspective, allogenic kidney transplantation would be superior as compared to hemodialysis. Another aspect which I just said verbally, you might have missed it, so I'm saying it again. A lot of people who are urine dipstick negative, because mostly, we use a dipstick to check for the urine protein, they would be having a significant amount of albumin present in the urine, but it would be below the threshold of a dipstick. So write this test for your CKD patients. Apart from serum creatinine, you must in the spot write on the case file, apart from KFT, you should write UACR, a urinary albumin creatinine ratio, so that you can correctly grade the severity of chronic kidney disease in the patient. We'll next focus on causes of chronic kidney disease in an individual. The first and the foremost, I said verbally, but I'm not describing or jotting it down before you, is diabetic nephropathy. This patient of mine was having type 2 diabetes mellitus. His HbA1c was constantly above 7%, poor glycemic control. He was not regular with his medications, and after 15 to 20 years with HbA1c constantly more than 7%, you could have is a diabetic nephropathy. The most common histopathological change seen here is diffuse glomerulosclerosis. The characteristic one is nodular glomerulosclerosis. There's a separate video on diabetic nephropathy where you can mention or go through for the histopathological terms that I'm mentioning at the moment. And one of another reasons why we are talking about this leading cause of chronic kidney disease, diabetic nephropathy, is because per se, though the kidney function is hampered, but the size of the kidneys would be increased. Other conditions which you are familiar where kidney size is increased so the function is hampered is HIV associated nephropathy. I'm not writing autosomal dominant polycystic kidney disease at the moment because that's very obvious. All of you know you get a gross renomegaly with large number of cysts in both cortex and medulla in autosomal dominant variety of polycystic kidney disease. So the diseases that I would like you to remember over and above ADPKD would be HIV associated nephropathy where you get focal segmental glomerulosclerosis, amyloidosis, and obviously diabetic nephropathy. Moving on to the second important cause, all the varieties of glomerulonephritis that you read, whether it's going to be crescentic glomerulonephritis or rapidly progressive glomerulonephritis, all of them will ultimately cause a burnt out kidney. They will cause a chronic glomerulonephritis, which happens to be the second leading cause for development of CKD. Point number 3 would be vascular causes contributing to damage to the kidney, like hypertension. Lots of time if it's not diagnosed, then elevated blood pressure can also cause damage to the kidney. Vice versa, kidney can be a cause of hypertension, elevated blood pressure can also cause damage to the kidney. My next patient is actually suffering from triple vessel disease. I had advised this patient to undergo a coronary artery bypass grafting, which he did not undergo. If a person with triple vessel disease is suffering from he's having an ischemic heart disease and he did not undergo a coronary artery bypass grafting, then he will suffer from ischemic cardiomyopathy. Due to this cardiomyopathy, the cardiac output will be persistently low. Therefore, the blood supply to the kidney will also be low. And this persistently reduced blood supply to the kidney will cause damage to the cortex and the medulla. Mostly the most hypoxia prone part of the kidney, as I've explained in acute kidney injury section, is also the outer medulla. So ischemic kidney damage on the long run can also contribute to chronic kidney disease in an individual. Or instead of writing ischemic kidney disease, he might write cardiorenal syndrome. See, the problem started from the heart and then went on to involve the kidneys of the person as well. The fourth cause is easier to remember, autosomal dominant polycystic kidney disease. And if he says what is the leading cause of death in ADPKD, again don't answer uremia, renal failure, catabolism, malnutrition. Your answer would still be increased cardiovascular mortality. The 3 times I've said increased CV mortality, leading cause of death in CKD, leading cause of death in a person of CKD undergoing hemodialysis, again CV mortality, and ADPKD again is cardiovascular mortality. The 5th cause to be remembered is tubulointerstitial diseases of the kidney. I have recorded a separate video in the app by the name of ciliopathies. In ciliopathies, I've described the various tubulointerstitial diseases, and they can contribute to again decrease in the glomerular filtration rate, and chronic kidney disease can ensue in an individual. These 5 causes that I mentioned before you, these 5 constitute, this is what Harrison says, the type 5 constitute 90% of all cases. The top 5 constitute 90% of all cases of chronic kidney disease that are seen on a global basis. And out of these 5 causes, if we ask you to select one, then the answer by yours would be given as DG hat, because of the fact that you reading it for first time. A quick mnemonic here: DG hat, D would be diabetic nephropathy, G would be glomerulonephritis, H would be hypertension, A would be autosomal dominant polycystic kidney disease, and T would be for tubulointerstitial disease of the kidney. Now, once we get the causes right, our next objective would be to check out what would be the clinical features that would be developing in our patients of chronic kidney disease. Why would they come to us? One of the important reasons why they come to us would be decrease in appetite and weight loss. Most of the time, catabolic processes are gonna be predominant in a person of CKD. So you need to regulate protein intake, because if a person of CKD, like if the general question says what should be the protein intake in a person with CKD, since he's having damage to his kidney, proteins will not be metabolized also. So we need to go in for a protein intake of 0.8 to 1 gram per kilogram of body weight. But when the same person will undergo hemodialysis, then protein intake has to be increased to 1 to 1.5 grams. I repeat once again, though I'll mention it in the treatment part as well, you need to restrict the amount of proteins to 0.8 to 1 gram dependent on the GFR values and the creatinine values. And in case a person starts undergoing renal replacement therapy in the form of hemodialysis, then the protein intake has to be increased to 1 to 1.5 grams. Now, initially, these patients would come to us with decreased appetite and weight loss. Urea will cause damage to the stomach mucosa. It irritates the stomach mucosa. So these patients will say, I don't feel like eating anything. I feel pukish most of the time. So nausea. And then urea, which is gradually accumulating. I mean, there are large number of toxins that accumulate in kidney failure. So your patients would also be having is a large number of, because it will irritate the diaphragm. So your patient would be having nausea and hiccups. So initial complaints can be relatively non-specific. But what will draw your attention to the fact that the kidney can be involved is that this person is having a pedal edema. This is because of volume expansion. In fact, sometimes the edema component, the volume expansion can be so much that a chronic kidney disease patient can deteriorate into acute kidney injury, and then the volume expansion, which is already increased, might increase to such a large level that these patients can develop pulmonary edema and a breathing difficulty as well. Most of these patients, when they come to you, would also be having problems with their neuromuscular system. Uremia can cause damage to the neuromuscular junction, neuromuscular functions per se. So as early as I can say stage 3 of CKD. In the earlier part, I was teaching you that stage 3 of CKD will present with anemia and pallor. Yes, that will happen. But along with this, even problems with, I would say, neuromuscular disease is evident. Let me just jot it down. I'm saying neuromuscular disease related complications or symptoms can be present as early as stage 3, which would constitute muscle cramps. Some of them would be having twitching and irritability. At the moment, I'm not talking about irritability from the perspective that his mental sensorium is affected. Later on when there's an encephalopathy, then the sensorium of the patient will also be affected. But usual mood swings, twitching, muscle cramps is what is incorporated or is seen in these patients initially. Pruritus is something that we encounter mainly with liver damage, especially in obstructive jaundice, but even in uremia as the toxins. It's not only about urea creatinine, there are large number of other toxins that accumulate in the body. So pruritus will occur. These patients will also develop skin pigmentation. And as the disease progresses, the breath of these patients might be having a smell of urine. The breath of the patient is having a smell of urine, which would be uremic fetor. Along with this, restless leg syndrome, like when this person will sleep, then he will complain of cramps in his legs the moment he tries to sleep. Restless leg syndrome has multiple causes. It could be familial, it could be idiopathic, it could be anemia, and even chronic kidney disease. At this point of time, as the kidney function is deteriorating, high RAS stimulation or neurohormonal stimulation will contribute to elevated levels of aldosterone, and hypertension will ensue. Then when you are taking the history of the patient, past medical history and family history also matters, because why am I taking medical history of this patient's family members also apart from him is because when you read about Alport syndrome, like Alport syndrome can, though that's a rare cause, but then Alport syndrome tends to have sensorineural deafness with lenticonus and end-stage renal disease occurring in the patient, and because it's genetically acquired, so auditory complaints are also to be taken into consideration. Similarly, person could be having visual problems. Person can go blind. So visual complaints are also to be considered while taking history because of a disease that is cystinosis, though that's a relatively rare one, but has to be taken into consideration per se. And then even skin issues or integumentary. Why am I describing that is because another raised, I would say, a rare cause, but causes CKD in a patient is Fabry's disease. So point number 8 is just to tell you, that I will not only inquire in the patient with respect to auditory complaints or visual complaints or integumentary complaints over and above the pruritus and the skin pigmentation, because these are rare facts. So I just need to give a justification for it. In medical history, when I was evaluating why did I get into this integumentary complaints from the patient's perspective or family history perspective, because I am taking into consideration angiokeratomas. Angiokeratomas is what we read with respect to Fabry's disease, visual complaints from the perspective of cystinosis, auditory complaints from the perspective of Alport syndrome, which is a defect of type 4 collagen, and you always have this triad being asked, that is a lenticonus with a sensorineural deafness, and then more importantly, end-stage renal disease that would be occurring in the individual. Then in the history part, you also need to take into consideration exposure to heavy metals. So occupational history will matter, because exposure to heavy metals can cause chronic tubulointerstitial disorder, CTID. I mean, the last cause, when I described the mnemonic DG had to you, the T was standing for not toxins. T was standing for tubulointerstitial diseases. So heavy metal exposure can cause chronic tubulointerstitial disorder. Then I'll also talk about exposure to Chinese herbal medicines, because Chinese herbal medicines would be exposure to Chinese herbal medicines. Yeah, that's pretty interesting. I mean, though these are available, there are a couple of pharmacies also. The Chinese herbal medicine would be having this product that is having this peculiar name, that is aristocolic acid. This aristolochic acid is present in this Chinese herbal medicine and can contribute to damage to the kidney. And there's another term that you read about it that's found in Europe, that is Balkan nephropathy. So Balkan nephropathy or Chinese herbal medicine have these common ingredient present, which could result in damage to the tubules of the kidney. Plus, on physical examination, I'll be doing a fundus examination of the patient. Why that's important is because diabetic retinopathy and diabetic nephropathy progress at the same speed. Diabetic retinopathy in type 2 diabetes again takes 15 to 20 years to develop. So if a person with diabetes is having a retinopathy, that means kidneys have to be scanned, and if the kidneys are involved, then the eyes also have to be scanned. And then I'll also do a cardiovascular examination of the patient. In cardiovascular examination, one thing that I like to focus is pericardial friction rub, because a lot of these patients subsequently will develop uremic pericarditis. That uremic pericarditis, guys, is an absolute indication for hemodialysis. Yes, absolute indication over and above encephalopathy. Like suppose you get a question, absolute indication for hemodialysis is. And in the MCQ, he mentions uremic pericarditis and uremic encephalopathy. The first thought process is it looks like uremic encephalopathy. No, your first answer for, and I'll explain the reason for that also as we progress in the discussion with respect to indications for hemodialysis. But at the moment, I'm telling you, without jotting it down, absolute indication for hemodialysis is uremic pericarditis. So in this particular slide, I've tried to explain to you the symptoms that would come in the patient, and when you're taking the history of the patient, then what are the additional aspects which must be taken into consideration, with special emphasis on fundus examination and the occupational history component to be taken into consideration, so that we can narrow down to what reason could be responsible for development of chronic kidney disease in these patients. Now, next up, I'm going to describe to you management of a person of CKD, and the mnemonic we can remember is ABCDE, where alphabet A would be standing for controlling glycosylated hemoglobin of the patient under check. You see, because a large number of chunk of our patients with CKD are having diabetic nephropathy, so whatever had to happen has already happened. What I can try now is, at least for the remaining years of the life of this person, I must try to attain a good sugar control, and thereby I must ensure that the HbA1c of the patient goes to less than 7%. In a large number of these patients, especially Indian patients, we would be having these patients already on metformin, and metformin is excreted via the kidney. So you need to stop metformin if the estimated glomerular filtration rate of the patient is less than 30 ml per minute. There's a range given in the textbook that is 30 to 45 ml. I've taken the lower limit here, and God forbid if a doctor continues to give metformin in spite of, he did not calculate the EGFR or there was a miscalculation. If you continue giving metformin to a patient of CKD and his EGFR is less than 30 ml per minute, then this chap will end up with development of lactic acidosis, which would be a gross medical negligence. So every time you're giving metformin to diabetics with a diabetic nephropathy, EGFR must be documented. If you stop metformin, then what is the drug that is to be started? The current guidelines say that because majority of CKD patients have an enhanced cardiovascular mortality, and instead of metformin, what you can initiate in the patient is SGLT2 inhibitors. There will be a double advantage. SGLT2 inhibitors are not only going to control the blood sugar of this patient, but they will also reduce cardiovascular mortality. Now, let me say, because of the cost component, if you're not able to introduce SGLT2 inhibitors, or let me say they're not available, whatever, then there's another drug that I'm mentioning, which is a sulfonylurea, but is metabolized by the liver. So we can start the patient on glipizide, or we could be starting the patient on DPP4 inhibitors. Majority of DPP4 inhibitors like sitagliptin are again metabolized by the kidney. I need to give drugs which are metabolized by the liver. So I'm using this opportunity to refresh your pharmacology also. That is, my objective is to reduce the chances of development of lactic acidosis. How would I do it? One option is I start the person on SGLT2 inhibitor, which is recommended. Otherwise, glipizide or linagliptin, which are metabolized by the liver and would be suitable for patients of diabetic nephropathy. Ideally, in all of these patients, because already there is a substantial amount of damage, we must advise the patient to start on insulin, at least if the HbA1c is in excess of 11%, going up to 12-13%, as is the norm. In poorly controlled diabetes mellitus, we must advise these patients to start on insulin so that we can have is a good glycemic control. Now the issue again arises, where is insulin metabolized from? Is it metabolized by the liver or by the kidney? Then the answer is kidney, and the problem is kidney is not functioning. So he has also asked that if you initiate insulin in a patient of diabetic nephropathy, or let me say he is already on insulin for a large number of years, now he's ended up with diabetic nephropathy because he was not regular or the dose of insulin was not proper. He says, what should you do with respect to the dose of insulin? Should you give more than the prescribed, whatever is the X amount of insulin that you've calculated on the basis of body weight of the patient? Should you continue with the same dose of insulin for glycemic control? Should you cut down on the total amount, or should you give excess of insulin? Then the logic is simple. Insulin is excreted by the kidney. If it's not going to be excreted, it's going to accumulate and will cause hypoglycemia. So whatever dose that you have calculated on the basis of various formulas available, you just need to give 80% of the calculated dose. Though in the exam he did not ask you specifically the value, he only asked that in a person of diabetes mellitus who has currently developed diabetic nephropathy, the insulin dose adjustment would be. The answers were like insulin should be given more than normal or reduced or constant dosage. Your answer would be it should be given at a reduced dosage. Once we have taken care of the A component, I'll next take care of the B with respect to A, B, C, D, E mnemonic. And in all of these patients, because there is hypertension, there's a high renin hypertension. So I need to establish good blood pressure control because hypertension itself causes damage to the kidney. The question then arises is, what should be the target blood pressure in a chronic kidney disease patient? You see, there was a lot of controversy because a lot of apps were mentioning 140 by 90 millimeters of mercury. But currently, the current edition of Harrison, as well as the latest, most textbooks currently mention that the target blood pressure in CKD should be kept at or below less than 130 by 80 millimeter of mercury if achievable. What I mean by achievable is that I don't want the person to develop postural hypotension, or like, let me say, if I try to be too aggressive, if I increase the dose and that contributes to hypotension and then maybe orthostatic hypotension and a fall in a person ends up with a head injury, then I've caused more damage than the benefit to the patient. You see, the moment you try to lower blood pressure beyond a critical threshold, there's a possibility of cerebral ischemia developing in a patient, though it might be transitory and syncopal episodes can be developing. Why I'm emphasizing that is because a lot of diabetics could be having concomitant diabetic neuropathy. And if they have a diabetic neuropathy, they can end up with autonomic neuropathy. And this autonomic neuropathy can cause a orthostatic hypotension. So you need to balance out, because I don't want the person to have syncopal episodes or disease spells present. I want him to be comfortable. So he says if achievable, but this is ideally recommended and reduces the progression of damage to the kidney. The standard data is both in diabetic nephropathy / if he says diabetic nephropathy or he says CKD, then your answers would be that ACE inhibitors are the preferred drugs because they have been documented to slow the decline of glomerular filtration rate. At this, the query of most people is, sir, one of the side effect of ACE inhibitor is hyperkalemia. And you are saying that you will give ACE inhibitor to the patient who's already having a hyperkalemia. Let me say he's G3B going towards G4 category of GFR. Then would you still give ACE inhibitor to the patient? Then he says yes, but you need to keep a watch on the potassium values. So I'll explain to you what would you do if the potassium begins to rise. But he says initially the initial approach of yours would be that either you should give ACE inhibitor to the patient or you could be giving angiotensin receptor blockers, because every time there's a decrease in GFR, there is a high renin hypertension. So to neutralize or counterbalance this high renin hypertension, either ACE inhibitors or ARBs have been documented to show a decline of GFR both in diabetic nephropathy or chronic kidney disease due to any etiology per se. Now, when you give ACE inhibitor to a patient, there is a problem. And the problem is that it will cause a efferent arterial dilatation. So every time you are planning to start ACE inhibitor in a patient, you must calculate eGFR before starting. And then you must calculate eGFR even after starting, because the movement you will have is a efferent arterial dilatation. This efferent arterial dilatation can cause a slight reduction of the glomerular filtration rate. Yes, guys, ACE inhibitors have been reduced the progression of damage in the kidney, but when you give them, there is a side effect that would be a slight reduction in the glomerular filtration rate of the patient. The query in your mind would be, sir, how much can we tolerate? I mean, if the GFR of a person reduces, till what level would you still continue with ACE inhibitors, and beyond which level would you say that, okay, I'm going to discontinue ACE inhibitor? So it says slight reduction of GFR can occur up to 30% of the baseline. I'm not saying GFR is becoming 30. I'm saying 30% of whatever was the baseline value. Till this, you can still wait and watch and monitor the patient. But in case there is a progressive, if there is a progressive fall of the glomerular filtration rate of the patient, or earlier the guidelines were given in values of serum creatinine. Like suppose it is 1.5, increases from 1.5 to 2 milligram over this much time. Now it says instead of serum creatinine, because serum creatinine can be falsely normal in CKD due to muscle wasting. So he says if the GFR falls up to 30% of baseline, you can still wait and watch. But if there is a progressive fall or a progressive decline, then you must discontinue ACE inhibitor / angiotensin receptor blockers, and you can start the person on calcium channel blockers. Another problem that would creep up is that ACE inhibitor will always have a side effect of contributing to hyperkalemia. So he says, what can you do to manage the hyperkalemia of the patient? You see, the benefit of ACE inhibitors is tremendous, but there is a coexisting, vexing, irritating problem of hyperkalemia. So he says, first try to handle the hyperkalemia component. If you're not able to handle it, then it is okay. Then you discontinue ACE inhibitor. So I'm not saying that if there is a persistent hyperkalemia, potassium going up to 6, 7, 7.5, I am still going to be insistent with use of ACE inhibitor. No. He says what you should do is that the moment a CKD patient comes to you, you have given ACE inhibitor to the patient and potassium is, let me say, 5.5. Instead of being, let me increase it, 6, 6.5, I must ensure that I'm giving diuretics like furosemide to the patient, because this would help in polyuria and will decrease the potassium values in the patient, and I can call the patient again for a follow-up. Suppose the potassium is still not reducing, or rather furosemide, because it's going to cause diuresis, it will have a couple of, I would say, not exactly I would say disadvantage, but yeah, from the patient's perspective, going to the washroom again and again is something that is irritating. So an alternative drug, which is a novel potassium binding agent, that is patiromer, can be given. You see, in acute hyperkalemia, we tend to give insulin drip, give calcium gluconate to the patient, salbutamol nebulization, that I've discussed separately. In the cardiology section, I've also discussed management of hyperkalemia along with ECG changes. Even in acute kidney injury section, I've talked about management of acute onset hyperkalemia. But here I'm trying to tell you that if a person is having a long-standing hyperkalemia, then what are your initial approaches? Then initial approaches is try to kick out either via urine or give a novel potassium binding agent. But he says that if still potassium is high, in spite of the drugs that I have mentioned, then you need to stop ACE inhibitors in a patient. So you can understand that it's not a simple job. I mean, it's just not that you, like, on one hand I was saying no, ACE inhibitors are like the best drugs and they slow down the progressive decline, but you need to keep a watch on the GFR values, you need to keep a watch on the serum creatinine values, and you need to keep a watch on the potassium. And in case there is a progressive decline of GFR and a progressive rise of potassium in spite of medication, that is when you discontinue. And then what are you going to do? So your answer would be that, okay, no problems, I can introduce alternative drugs and I can be introducing calcium channel blocker in the patient. In fact, if my same patient goes into what was formerly called as end-stage renal disease or end-stage kidney disease, I've explained to you currently the term used is renal failure, which means that if the estimated GFR of the patient goes to less than 15 ml per minute, then I'm using the max dose of calcium channel blockers, I'm giving diuretics, but still problem is occurring. So if he goes into ESRD and the eGFR is lesser, then to the calcium channel blocker, I can add, he says, add alpha-1 blocker, like you can be adding prazosin or terazosin. So CCBs and alpha blockers can be given to patients if they go towards end-stage renal disease. The diuretic which can be given along with furosemide is metazolone. I'm not mentioning about metazolone at the moment. My main focus is that if potassium is very high initially, I mean, instead of metazolone, I'm going to give furosemide. Then I can combine furosemide with metazolone, patiromer, and yep, if the blood pressure is still not controlled, then I have to use calcium channel blocker with alpha-1 blockers for these patients. Beta blockers, should they be used or not? Yes, a lot of these patients would be having a concomitant cardiovascular mortality. So if they have, like he has been documented to have a double vessel disease or a single vessel disease, or he's already undergone a stenting, in one of his coronary arteries, then his cardiologist would have anyway started him on a beta blocker. So I try to introduce those drugs because lots of time these patients may be already on a beta blocker because of the cardiovascular issues. So the drugs that you can use is CCB and alpha 1 blockers in these patients as they progress towards end stage renal disease. Now we focus on alphabet C for the management of this patient. I've taken care of HB1C, A, then B is blood pressure control, C is for cholesterol, D is for vitamin D, and E is for erythropoietin. Just thought I'll mention the mnemonic initially, and K is for the potassium values anyway. So the third thing that I need to do is that I need to handle the cholesterol values of this patient, and the bad cholesterol especially is of interest here, that is LDL. He will again say what should be the target LDL in this person. Then the target LDL in this person should be answered as less than 70 milligram percent. You see, if he's already had a MI also, like let me say this chap, he had a MI, he's a known case, cardiovascular problem is already present in the patient, now he's having diabetic nephropathy as well, then the target would be 55. I'm saying if somebody is already, three things, so I said diabetic, plus already had a MI and is also having a deranged lipid profile, then I need to keep cholesterol under check. I need to control the elevated cholesterol of this patient. So I can be starting these patients on statins, that is high intensity statins. In kidney damage, which is the preferred statin, then there's a line in Harrison in diabetic nephropathy topic. He says that atorvastatin is recommended in patients with renal damage. So I can be starting this patient on atorvastatin. They will not ask you the dose. What they will write in the MCQ will be high intensity statin. So yes, because of the high risk of cardiovascular mortality, we will give high intensity statins for management of these patients with respect to the hypercholesterolemia component. And most of the time, these patients, if not intervened, can deteriorate. In fact, I've been very vocal about cardiovascular mortality, so I can currently give you an example of Sushma Swaraj ma'am. She was topmost politician in BJP one government and was a minister in Ministry of External Affairs. And ma'am was a diabetic. Being a busy politician, she did not take care of her health, so she went into diabetic nephropathy to the level that she developed ESRD, and then she had to undergo a kidney transplantation at AIIMS Hospital. So why I'm telling you this is because a famous politician who has access to best medical care, she underwent a kidney transplantation, but then ma'am expired subsequently because of myocardial infarction. She took a meeting of IS officers in the morning, and by evening she was feeling unwell and she expired at her house only. So why I'm telling you this is that people in such high position who have access to best medical care, if they are going to suffer, then you can understand. Ordinary people with limited amount of medical care, the suffering would be much more gross. So our objective would be to educate the patient of CKD with respect to the cardiovascular issues, which may not be present at the moment, but can develop in these patients in future. The D part of the mnemonic will be the most exhaustive one that you need to remember. You see, kidney is responsible for synthesis of vitamin D3. While I'm writing this, the question to you guys is, which part of the kidney would you be having synthesis of vitamin D3? Where is 1-alpha hydroxylase enzyme present so that the synthesis of 125 dihydroxycholecalciferol is hampered? Then your answer would be proximal converted tubule is where 1-alpha hydroxylase is present, and that's where the synthesis of vitamin D3 takes place. But because the kidney is damaged, therefore the production would be lesser. Now, once the values of vitamin D3 is lesser, all of these patients would be having a hypocalcemia, and the problem with this hypocalcemia would be that this will activate the calcium sensing receptors which are present on the parathyroid gland and will cause increase in the production of PTH. And I'm writing it as secondary hyperparathyroidism because you're familiar that primary hyperparathyroidism is parathyroid adenoma, and secondary hyperparathyroidism would be due to the topic we are studying, that is chronic kidney disease. Over and above this, we will also have is a gross elevation of phosphate, and the reason for this elevation of phosphate is because there is a low GFR. See, PTH is increased, that's okay, but it's not able to excrete this phosphate load because the glomerular filtration rate of the patient is lesser, and this increase in phosphate can again contribute to multiple problems for the patient. Phosphate is directly related to cardiovascular mortality. In fact, there are three things that I would like to mention for elevated phosphate. One, this elevated phosphate can chelate with calcium and can cause a hard mass. This hard mass can develop in extremities of the patient. This hard mass that will develop in the extremities would look like a tumor, so it's called as tumoral calcinosis. The point that I'm trying to explain to you is that if in our body, what I'm saying next you don't need to note down, if in our body the multiplication product of calcium and phosphate goes more than 55, then the two can chelate and can form, I mean, they can contribute to calcification in the body. So it's not that only elevated calcium, because the normal thought process of ours is that elevated calcium will contribute to calcification of a tissue. What I'm trying to teach you is that it is not necessary that calcium is more and only then calcification of a tissue will occur. Calcium could be less, but if there is a disproportionate rise of phosphate, even then, mathematically speaking, calcium is less, okay, but phosphate is disproportionately increased. So still the combination of the two can contribute to calcification of tissues, and therefore tumoral calcinosis can occur. Another problem that is seen in these patients due to elevated phosphate is calciphylaxis. Now, this is itself a question. I mean, we read the term anaphylaxis, but I'm teaching you regarding calciphylaxis. So the manifestation that occurs in calciphylaxis would be painful livedo reticularis. Livedo reticularis would look like this would be appearance of blood vessels in the skin that would look like spider's legs, and this would be painful in the person. Apart from this, the painful livedo reticularis, it's not that it's limited to only the extremities. It could be abdominal wall on the thighs of the person. And the most important part is the calcification will occur of the blood vessels, and therefore this phosphate is directly related to cardiovascular mortality. Earlier, I was just saying no increased cardiovascular mortality, but now I'm telling you, and the question will say, which of the following electrolyte imbalances predisposes to enhanced CV mortality in a CKD patient? Your answer is not calcium. Calcium is lesser. It is elevated phosphate, which is why we'll be talking about phosphate binders that would be given to these patients. Additional problem that will occur in these patients is increase of PTH. And what does PTH do? PTH causes bone reabsorption. Because of this bone reabsorption, this person would be having what you study in pathology as osteitis cystica fibrosa. We read about osteitis cystica fibrosa not only in primary but even in secondary hyperparathyroidism. PTH is removing calcium from the bone, so it's causing cyst formation in the bone. And because there's a cyst formation in the bone, there can be bleeding inside the cyst also. And when this blood will degenerate, it will produce hemosiderin. Hemosiderin is brownish in color. So you will read this term, which is written in a lot of questions also, brown tumor. Brown tumor is actually a misnomer because obviously there is no tumor. Brown tumor occurs because of hyperparathyroidism, and it is seen in patients of chronic kidney disease where there would be damage to the bones in the patient. Instead of writing regarding terms like osteitis cystica fibrosa, he might mention another fact, that when the x-ray of the hand of this person was done, I mean, you would have read this even in your orthopedics classes, this classical term, either he will say scalloping of phalanges, or scalloping is a very classical term. So he will say, instead of scalloping of phalanges, he will say subperiosteal reabsorption of the phalanges. So, I mean, these terminologies would help you understand that he's talking about CKD and he's mainly talking about increase of PTH. So there are two gross problems that I need to handle in this patient. One, I need to control the phosphate values by using phosphate binders. Otherwise, all these problems will increase. And second, I need to give drugs which will reduce the production of PTH. So I will be now dealing or talking about the main interventions that we're doing. You see, the standard first line thought process is, okay, vitamin D is lesser, let me give vitamin D3 to the patient. When we give vitamin D3 to these patients, rather this vitamin D3 we can cause, because patient will be given large amounts of vitamin D3, you will not be monitoring serum vitamin D3 levels. So vitamin D3 levels can rise and can go even higher than normal due to supplementation. That will drive up calcium, and calcium, if goes up, you look at this mathematics here, it will worsen the calcification component. I'm saying indiscriminate usage of these patients, indiscriminate usage of vitamin D supplements can contribute to worsening of these patients. Similarly, we use phosphate binders like calcium acetate. Calcium acetate again has calcium, and this phosphate binder, that is calcium acetate, can again cause calcium values to spike up. And once this mathematical formula is satisfied, then again all these problems in the person can worsen. So initial thought process of ours is, and this is what we used to do initially, that for all patients with CKD, we used to give them large amounts of calcium and vitamin D3 without monitoring their vitamin D3 and calcium values, and rather we used to have worsening of the actual problems of the patient. So let's now focus on what we can do to handle the problems of this patient. The two fundamental problems is elevated phosphate and elevated PTH. So in point number 4 itself, I'll have changed the slide. In point number 4 itself, one, I'll be describing before you the phosphate binders that we are going to use. You see, phosphate binders again are of two varieties. One are calcium based products. We can use them also, but he says less recommended. Rather, non-calcium based phosphate binders are the ones which are recommended. So first I'll write down the names of the traditional ones, the cheaper ones like calcium acetate or calcium carbonate. I mean, most of these pharmaceutical companies, when they come to you, they will show you their tablets which are having calcium and vitamin D, and we get influenced by our pharmaceutical people, the medical representatives, and we start writing indiscriminate amounts of calcium and vitamin D to these patients. What ideally should be done is phosphate binder, non-calcium based should be used, and that is itself a question to you. Which of the following is a preferred phosphate binder in CKD? Even in a pharmacology classes, you are taught about this drug, that is sevalimer, which will prevent this disadvantage of spiking calcium and worsening of tissue calcification, tumoral calcinosis, or calciphylaxis that can occur in these patients. Another drug that you should be aware of from your pharmacological domain is lanthanum carbonate. So two important phosphate binders that I want you to remember are sevalimer, lanthanum, and then obviously the calcium ones, calcium acetate and calcium carbonate, are also available. Let us now look at what we can do for management of elevated PTH in the patient, because elevated PTH will cause worsening of that osteitis cystica fibrosa and a brown tumor manifestation. So the drug that I'm gonna give in this person is a calcimimetic drug. What I mean by calcimimetic is that it is not calcium, but it behaves like calcium, and because it behaves like calcium, it will tell this KASR. You see, KASR is the calcium sensitive receptor. It is responsive to less calcium. When you give a drug that looks like calcium but is not calcium, it will stimulate this KASR and will inhibit PTH production. I repeat once again, in you and me, inhibition of PTH production occurs when calcium values in our body tend to become normal. If it is lesser, PTH is produced. If values go back to normal, then PTH production is suppressed. So we are giving a drug which is giving a false illusion to the body, to the receptor, that okay, everything is fine, shut down this PTH production. And the name of the drug that you should be aware of is cinacalcet. So most of the time, if he wants to trouble you from the pharmacological domain in a CKD topic, he's not going to ask you about ACE inhibitors and alpha blockers, which are used in end-stage renal disease, which is, I would say, easier for you to crack. He would be more interested in talking about aspects related to vitamin D metabolism. And as I explained, I mean, which electrolyte imbalance contributes to, or which increase of which of the following enhances cardiovascular mortality, then hyperphosphatemia is to be given as an answer. So before we move forward in this topic, I would like to utilize this opportunity to mention regarding a couple of electrolyte disturbances or electrolyte imbalances that can be anticipated in patients of chronic kidney disease. You see, all CKD patients will be having increase of aldosterone. So this will cause an increase in total body water as well as total body salt. You're noticing TBW means total body water. I put two arrows in front of it. Total body salt, I put a single arrow in front of it. So one, I just want to remind you that I've even mentioned in the electrolytes topic that patients of CKD would be having a hypervolemic hyponatremia. Why hyponatremia? Because two arrows for water and one for salt. So I can say there's a dilutional component present. So increase of total body water and increase of total body salt, both would be because of aldosterone. But because of this disproportionate rise of water, these patients would be having a hypervolemic hyponatremia. So sodium in these patients would be lesser, and what you can do for management of this hyponatremia would mostly be water restriction. Because of impaired GFR, potassium will be retained in the body. In patients of CKD, you can even get a hypokalemia. Now the surprising thing is, and the query of most people is, sir, you are saying hyperkalemia, understandable, that's what we studied. How hypokalemia? This hypokalemia occurs mainly because of excess usage of diuretics. Because in any patient of CKD, on the long run, there would be pedal edema, and then even a periorbital edema, and subsequently even a pulmonary edema. So we tend to go a little aggressive on diuretics, and excessive use of diuretics can trigger hypokalemia. So both electrolyte imbalances are possible in CKD. At one time only one will be present. I'm not saying that both hyper and hypo can be present. What I'm trying to explain to you is that initially it could be hyper K, and because you're using excessive large amount of furosemide, then the same patient after 1 week could be having is a hypokalemia component also. Plus there is a retention of phosphate, hyperphosphatemia, and calcium in the patient is lesser. The reason why calcium is lesser is again because synthesis of vitamin D in these patients would be reduced. At this juncture, I can also mention for one-liner questions, what would you be doing? So if he says a CKD patient is having a hyponatremia, he's not saying patient is having seizure. He's just saying patient is having hyponatremia. What would you be doing to manage this patient? Your answer would be water restriction, and that should take care of this imbalance in the arrows that I mentioned. For patients who are having hyperkalemia, nowadays he remembers or he recommends usage of a novel potassium binding agent, that is patiromer. When it comes to hypokalemia, what you need to do is decrease the dose. I can't stop them, so I can decrease the dose of diuretics and I'll have potassium coming back to respectable values. For hyperphosphatemia, there are multiple approaches, but sevelamer will be the first answer in the question, though I mentioned about lithium carbonate, and then I also mentioned regarding calcium acetate being used. In fact, I'll mention about a disadvantage of calcium acetate once again. And if calcium is low, then one approach is to give calcitriol, vitamin D3, which is easily available. Cheap options are available in the market, and we tend to use indiscriminate amount of it. What he says is that instead of giving calcitriol to the patient, you should give a calcitriol analog, that is peri. I'll just write down the spellings initially so that you can get it from the pharmacological perspective, right? That is pericalcitol. No, I'm not talking about cinacalcet at the moment. I'm talking about pericalcitol. So let's delve into what is pericalcitol all about. This molecule is a calcitriol analog. Now let's look at what is the advantage of it. The advantage is, one, it will help in stabilizing the calcium back to normal, but studies have shown that it also causes the PTH suppression, because in patients of CKD, PTH is elevated and that PTH is causing bone damage. So I also want to cause is a PTH suppression in the person. So there are two advantages. One is that it will help in stabilizing calcium. Second, it will suppress PTH. That does not mean that there is no need of cinacalcet. We will ultimately require cinacalcet in majority of cases. But I've just wanted to tell you that if he says, how do you manage the hypocalcemia component, then the drug that is recommended is not going to be answered as traditional calcitriol vitamin D3. Your answer would be a calcitriol analog, that is pericalcitol, because it has additional advantage of suppressing the PTH production. If he says what is the target PTH that is recommended in CKD, then do not answer normal. Your answer would be up to 2 to 9 times of normal. I repeat once again, what should be target? Because if you cause suppression of PTH, then again bone will be damaged. Your target PTH in the patient should be between 2 to 9x. If that looks surprising to you, let me introduce a term that will make it easier. He says if you go too aggressive, then there could be what is developing or is called as adynamic bone disease in CKD patients. What he means by adynamic bone disease is that CKD patient is coming to you, he will develop micro fractures in his spine, and he will come to you with severe musculoskeletal pain, and even pathological fractures can be documented. Like this CKD patient is watching Kapil's show, laughter show, and is laughing loudly, and while laughing, he might fracture his rib. So pathological fractures, severe musculoskeletal pain is a feature of adynamic bone disease that is seen in patients of CKD. In fact, the standard textbook will say like this: high bone turnover state, low bone turnover state. High bone turnover state is understandable. Elevated PTH will cause a high bone turnover state. But when would you be having a low bone turnover state is if you are having excessive, like if there is excessive use of either a phosphate binder, that is calcium acetate, or he says excessive usage of, a person is on renal replacement therapy and we are using calcium based dialysate or calcium rich dialysate solutions. So calcium rich dialysate solutions and excessive use of calcium acetate can actually result in suppression of PTH, and therefore once the PTH becomes lesser, then again there would be problems in the person, that is adynamic bone disease or low bone turnover state can be obtained. So you need to draw a fine balance. The problem of the patient is high bone turnover. He says decrease that to 2 to 9 times of normal. Don't decrease it to 1x and don't decrease it to less than normal, because then again pathological fractures can occur in a patient. So in the textbook you will read whenever vitamin D metabolism in CKD is present, he will say high bone turnover state, low bone turnover. High bone turnover state is the initial presentation of the disease, and low bone turnover is a complication of the treatment, complication of aggressive wrong treatment which has been administered to the patient. Like I said, we should be using sevelamer, which would be preferred over calcium acetate. We'll now focus on the E component of the ABCDE mnemonic, because kidney is responsible for production of erythropoietin, so anemia would come up. There are multiple reasons why anemia will develop. One is decrease of erythropoietin production. The second one is elevated PTH causes damage to the bone marrow. So most of these patients on the long run, earlier I was telling you that there is brown tumor formation. I'm telling you bone marrow fibrosis will occur because this is a chronic disease. So anemia of chronic disease would be occurring in the patient as well. The type of anemia encountered would be normocytic, normochromic anemia, plus the toxins which are present in CKD increase the risk of bleeding. There is an impaired platelet function in these patients, so bruisability or increased bleeding is seen in patients of both acute and chronic kidney disease. The combination of these factors will explain the anemia component, and then he will say what can you be doing to manage the anemia of this patient. Here I can tell you that a lot of people, I mean, obviously people like you and me will not do this unethical practice, but then some people do unethical practice in a sense that they start giving packed RBC because erythropoietin is less, anemia is there, so they will tell the patient you require packed RBC transfusion. Patient will say yes because he's not aware of anything, but when you give packed RBC to this person, you are rather causing a further suppression of the original erythropoietin production. Erythropoietin production is already suppressed in this person. You will cause a further suppression and will make the person transfusion dependent. So people who do unethical practice, we are here to learn ethics, but then unethical practice, people give packed RBC transfusions and rather make these patients transfusion dependent, and then this person will have to come to the hospital again and again. Obviously the hospital bills will increase and the doctor will make financial benefit, but then as I said, we are here to learn the ethical data. So he says what you should be doing for management of this patient is first take care of the iron stores in the body. So give parenteral iron. You can give IV iron to these patients. I'm not recommending intramuscular injections because bleeding risk is increased. So parenteral IV preparation can be given initially in these patients. And then erythropoietin stimulating agents can be given in these patients, though they also have their own disadvantage. But let's just quickly jot down the names here. The erythropoietin stimulating agent that we can be using in the patient can be either darbepoetin, which can be given either subcutaneously or intravenously, or another molecule that we can be using in the patient is apoetin. The advantage of these molecules is that you see kidney is responsible for production of multiple hormones. I mean, if I just have a look at the physiology domain, kidney produces renin, it produces erythropoietin, it produces vitamin D3. Renin is produced by the juxtaglomerular cells, we all know that. Erythropoietin, I'll put it to you guys because vitamin D I've already told you, proximal converted tubule. Yes guys, which cells in the kidney produce erythropoietin? Then from your physiology notes, you'll be familiar that peritubular cells in the kidney are responsible for production of erythropoietin. So three important hormones, renin, erythropoietin, vitamin D3 are ones which can be hampered as the kidney function will deteriorate, and erythropoietin vitamin D3 decreases and renin rather increases because there's a high renin state in the patient because of the feedback mechanism. I'll just make you revise the data at the moment. A was HbA1c, B was blood pressure control, C was cholesterol, D was vitamin D. I had to invest more time in that because usually vitamin D and phosphate issues are asked. And then E would be erythropoietin, that will explain anemia. And then we come to the K component, that is hyperkalemia, which would be occurring in these patients as they progress from G3 to G4 going on to G5. If there is a hyperkalemia in the patient, initially I can be using diuretics. The diuretic that is started in CKD patients initially is like thiazide, and usually the molecule that is recommended is metazolone. It is not that you cannot use the remaining ones. The advantage of metazolone is that it can be given even when the GFR is less than 30. I mean, lots of time you would have seen physicians writing chlorthalidone. Chlorthalidone has a disadvantage that if the GFR goes less than 30, then chlorthalidone cannot be given, and it is metazolone which is recommended. So I mean, metazolone will help in control the blood pressure of this patient as well. And most of the time, if the pedal edema component is pretty substantial, intermittently you might have to give furosemide plus metazolone for management of these patients. Kaliuria will occur, and this kaliuria will take care of the elevated potassium. Then a novel potassium binding agent, patiromer, I mentioned. When I was a student your age, and my consultant used to ask me, what do you use for chronic hyperkalemia in a CKD patient? Then I used to mention regarding this resin. This resin is called as sodium polystyrene sulfonate. This sodium polystyrene sulfonate, though some preparations of this has been documented to cause even a colonic necrosis because we used to give it in enema format, but still that resin is sodium polystyrene sulfonate can be given in form of enema and will help in stabilizing the potassium values in the patient. Another new drug that I can mention at the moment and will help in stabilizing the potassium values is sodium zirconate. So I have mentioned regarding three potassium binders per se. Patiromer, sodium zirconate, and sodium polystyrene sulfonate will help in stabilizing the potassium values in the patient. This medical therapy will continue on lifelong basis in all patients of CKD. And once he goes into G4 category of GFR, then I need to educate the patient regarding renal replacement therapy, where either kidney transplantation or hemodialysis would be required, and we'll next talk regarding the technical aspects of kidney transplantation. So by G4 or CKD, we have done a decision making that either we want to do a allogenic kidney transplantation where a first degree relative will be donating kidney for this person, or this person would be undergoing hemodialysis, and in pediatric cases we can make the patient undergo a peritoneal dialysis as well. For hemodialysis, as I've explained earlier, one session of hemodialysis would be approximately 4 hours. It's actually a range from 2 to 4 hours. So I've written the upper limit here. And the person would be undergoing dialysis 3 times per week. So you can understand that about 12 hours per week, he will spend attached to a machine. And apart from that, you need to inculcate or incorporate the travel time to and back from the hospital. So the quality of time is compromised, plus hemodialysis, recurrent hemodialysis increases cardiovascular mortality by causing accelerated atherosclerosis, and that is the reason why it has been mentioned in part number 2. And with peritoneal dialysis, which is done in children, we can do a CAPD also, that is a continuous ambulatory peritoneal dialysis. There will be a motor that will help us send fluid into the peritoneal cavity. There has to be retention time, and then the fluid will be removed. Peritoneal cavity is vast, and solutes can diffuse across this vast cavity, and we can remove the toxins, but the disadvantage with peritoneal dialysis can always be a development of risk of infection. Over and above this, peritoneal dialysis would be absolutely contraindicated in patients of autosomal dominant polycystic kidney disease, or would not be possible in autosomal dominant polycystic kidney disease, because the kidneys can be so big that they can occupy whole of the peritoneal cavity. So I'll focus next on point number 1 only, that is a allogenic kidney transplantation, where a first degree relative will be donating kidney for this person, and therefore we need to go in for matching. Matching is mandatory primarily because mitigate or reduce the risk of chances of rejection in the patient. So we would ideally prefer both a blood group matching as well as a HLA matching. And just for the sake of discussion, like you are aware that the gene for HLA would be on chromosome 6, my question to you guys is, while you're listening to this, on which chromosome would be the gene for blood group be located? Your answer would be chromosome number 9. So we need to do a proper matching here. But then he can ask you in which kind of transplantation HLA matching is not mandatory. You say HLA composition of any one of us would be some component coming from father, some from the mother. But then HLA matching is not mandatory in a transplantation where size matters. Like suppose we are doing a liver transplantation, or we are doing a heart transplantation, or even a corneal transplantation. TXR means transplantation. For liver, heart, and corneal transplantation, HLA matching is not mandatory. It is the size that really matters. Now, the testing which is to be done in the donor before kidney transplantation would be to rule out standard infections in the donor like HIV, hepatitis B, hepatitis C, and syphilis. But one of the important infections that I would like to mention at the moment, which can cause a graft failure in the recipient subsequently, would be cytomegalovirus. In fact, I can state a question at the moment: commonest infection that can cause a graft failure after solid organ transplantation or bone marrow transplantation slash hemopoietic stem cell transplantation. I mean, bone marrow transplantation can be written as hemopoietic stem cell transplantation. Your answer would be cytomegalovirus. And then we also need to do a imaging in the donor. Now, the imaging that we're doing in the donor is Doppler. And the query that I get from a lot of students is, sir, what is the advantage of doing a Doppler in the donor? You should be doing it in the recipient. You see, my point is, in the recipient, kidneys are already damaged. So it will not serve any purpose. It will not give any advantage. It is simply the fact that in the Doppler, when I'm doing in the donor, I am trying to rule out the possibility of unilateral renal artery stenosis, because you see, if a chap is having unilateral renal artery stenosis, then the opposite side kidney, the normal kidney, is doing all the hard work. If you remove that normal kidney from a chap with unilateral renal artery stenosis, you are leaving him with a diseased kidney only. So we must rule out unilateral renal artery stenosis in a person. If he's having bilateral renal artery stenosis, is anyway not a candidate for being a donor. But a person who's asymptomatic at the moment and is having unilateral renal artery stenosis, we must pick it up. At the same time, he can say what imaging can be done in the recipient whose gonna receive this transplant per se, in a sense that his kidneys are already damaged. You see, in kidney transplantation, we do not remove the diseased kidneys. The diseased kidneys will retain their position. You are gonna place the new kidney in the right iliac fossa, and when you place this kidney in the right iliac fossa, then it will get its supply from the iliac artery per se. I mean, that's the aorta that I marked out, and it gets supply from the iliac artery. So suppose if the recipient is having a iliac artery calcification, then that vessel will not be suitable for vascular anastomosis. The kidney has to get nutrition, it has to get blood supply from somewhere, and the supply that we routinely give is from the iliac artery of the patient. So in the recipient, the imaging which you will answer will be either a MRA or a CT angiography. Any of the two can be done, and the objective of doing a MRA is mainly to rule out iliac artery calcification, because iliac artery will be now the source of blood supply to the kidney. And though you're aware of it from surgery, I'll just say this, that in a normal individual, like if I am the donor for my family member, then I'll be made to undergo matching. The HLA matching will obviously occur along with these tests that I have mentioned. And the kidney of mine that will be removed will be the left kidney. The reason why the left kidney is removed is because the left renal vein is relatively longer, so it gives more flexibility to the surgeon to manipulate when it comes to vascular anastomosis. So it is the left kidney of mine that will be removed, but where will it be placed? So the left kidney of mine will be put in the right iliac fossa. And why are we putting the kidney in the right iliac fossa? I mean, one option is, yeah, we could have removed the diseased kidneys, but then if you have to remove the diseased kidneys, it will require a lot of extensive dissection, because kidneys are retroperitoneal organs. So the surgical morbidity part will be increased. The person will have to stay in the hospital relatively longer. So one point is, I'm not going to remove the old kidneys, let them be where they are. I'm going to deploy the new kidney in the right iliac fossa. And advantage of placing in the right iliac fossa is, you don't need to note it down, but just remember my fact that suppose God forbid, the kidney that you had transplanted underwent a rejection, then it will be easier to remove. You see, suppose you had placed the kidney at the original place, the retroperitoneal location, you will again have to do a deep dissection and then remove the rejected kidney. So again, the hospital stay of the patient will be substantially increased. So what we are doing here is the smart game. We let the original kidneys be at their original place, but we place the new kidney in the right iliac fossa. And I said, suppose God forbid, even if it gets rejected, it would be easier to remove. Whenever I speak about rejection, the questions that come in our mind would be that what would be the types of rejection. So it could be a hyperacute rejection, or it can be acute rejection, or it can be chronic rejection. So they can ask about hypersensitivity reactions also. And as far as HLA matching is concerned, you are aware from your basic classes also that HLA matching, the locus would be HLA-A, HLA-B, C, and then would be DP, DQ, and DR. And they can ask you that which HLA out of the 6 that I mentioned would be the ones which would be of interest to us for matching purposes. So the ones for interest for matching purposes would be HLA-A, HLA-B, and HLA-DR. Let me just write it down. I mean, what I'm doing next is only an academic exercise. It has, I would say, no great bearing from MCQ perspective. Let me say I'm writing HLA for myself on the left, and the right side is for my cousin. So let me just put down some random numbers there. That would be 2, 1 for HLA-A, then for B, then for, because why I'm writing 2 numbers is because we get some genetic material from our father and some genetic material from the mother. So just mention that in a numeric format. And then I am writing it for my first degree cousin as well. I've just inverted the numbers there. Some of the numbers I have inverted. Now this that I've shown is me, and this on the right hand side is my cousin. And you can see that because we belong to the same family tree, so there would be at least some amount of matching present. You see, we get half of genetic material from the father, half of genetic material, half of genetic material comes from the mother, half comes from the father. And because we belong to the same family tree, me and my cousin, so at least we are matching for at least 1 out of 6 match. You see, you cannot have a 6 out of 6 match. The only time you can have a 6 out of 6 match is if 2 babies are developing from the same fertilized egg. The genetic material of baby number 1 will be same as genetic material of baby number 2. So I'm gonna then use the term isograft. or I'm going to use the word syngeneic transplantation. So one, I want you to remember that syngeneic or isograft is where the genetic material of the two patients or two individuals would be the same. This would be possible only with respect to monozygotic twins, and not everybody would be having a monozygotic twin brother or sister. So that is where relatives, the importance of relatives comes in, that not everybody is going to have monozygotic twins. With syngeneic transplantation, chances of rejection would be negligible or not happening, but primarily because genetic material is identical. But like I said, if I do a match with my cousin, I am matching for, let me say, at only one side. So therefore, we also need to decide what kind of induction therapy and what kind of maintenance therapy would be required for the various levels of matches. Now, match is a word that is synonymous with USMLE residency, but suppose there is 1 out of 6 match or 2 out of 6 match, then the induction therapy would be given with ATG, that is anti-thymocyte globulin. But suppose a person is having 3 out of 6. I just wrote a couple of numbers there before you to represent HLA profile of mine versus my cousin. So suppose if 3 numbers are matching here, then the induction agent that would be used would be an anti-CD25 molecule. This is basiliximab. So one, they can ask you regarding the induction therapy that would be used in 1 out of 6 or 2 out of 6 match versus 3 out of 6 match. And when it comes to 4 out of 6 or 5 out of 6, I said 6 out of 6 is syngeneic transplantation, so that I've not written. But for allogenic kidney transplantation, if we are having a 4 out of 6 match or a 5 out of 6 match, then he says that no induction therapy is required. Once the induction therapy has been done for either 1, 2 or 3 out of 6 matches, as I've explained to you, using molecules, the names are ATG versus basiliximab, then in all of these patients, maintenance therapy would be started. This maintenance therapy will be with immunosuppressive drugs, and I'm also going to mention a mnemonic for the drugs which are to be remembered for maintenance therapy. How long would you give it? So your answer would be maintenance therapy after kidney transplantation would be given on lifelong basis, and these patients have to be explained that your immunity will decrease once you are on immunosuppressive medication. So you need to understand, they need to be explained the concept of barrier nursing. After kidney transplantation, if this particular person he's having visitors in his house, first he should cut down on number of visitors. Even if he's matching them or meeting them, he should ensure that he's using a mask. The relatives who are coming to visit him to inquire about his health are using a mask. Everybody takes off their shoes outside of the house to minimize the dust component, and he does not kiss children, or an old man underwent a kidney transplantation, and when he came back home, he kissed his grandchild, and the grandchild was having a URTA. Now, this chap who's already on immunosuppressive medication, if he gets the same viral infection that his grandchild was having and he kissed the grandchild, then this particular chap could even develop a viral pneumonia. Just to sensitize you to this, I can give example of Arun Jaitley, again, one of the leading ministers in BJP one government. He was the law minister for us, and he, being a busy politician, he was a diabetic, did not take care of himself, developed diabetic nephropathy. And post diabetic nephropathy, he underwent a kidney transplantation, and post kidney transplantation, he developed an infection because of the fact that this I would say barrier nursing concept was violated or was neglected in a temporary, I would say, event where he got infected from maybe one of his security staff, or maybe got infected from visitors to his house. So it's very important that these people are taught about the concept of barrier nursing, and the mnemonic that I would like you to remember would be STMA, where we have to put this patient on steroids, which would be prednisolone. Alphabet T would be, which I think you would have guessed it by this particular point of time, tacrolimus. Most of the patients would be on these 3 drugs, that is steroids, tacrolimus, and mycophenolate. Instead of using tacrolimus, another drug may also be used and is written in the textbook, that is cyclosporin. So initial approach for all patients undergoing a kidney transplantation would be to check out what was the level of match, whether they require induction therapy or not, and then maintenance therapy in the patient would be started. Alphabet A would be standing for azathioprine. In earlier times, azathioprine was the initial approach that we were using for the patient. But as of now, that is a backup approach. So most of the patients would be on STM, that is steroid prednisolone, tacrolimus, and mycophenolate. This would be continued on a lifelong basis, and opportunistic infections can develop in these patients, especially because they are on immunosuppressive medication. So though my objective is to minimize the chances of rejection, the types of rejection that can occur can be 3 of them. Hyperacute rejection, I said that verbally, acute and chronic rejection. While I'm writing it, I'm giving you some time to think about what is the type of hypersensitivity reaction that should be answered by you. Hyperacute rejection will occur due to preformed antibody within minutes. So the moment you establish a vascular anastomosis, the moment the recipient's blood starts flowing into the new kidney, the preformed antibodies are causing a damage. So because I'm saying antibodies, it would be easier for you to remember that the type of hypersensitivity would be type 2 hypersensitivity. But when it comes to acute, this acute rejection of the kidney graft can occur within the first 6 months. If it occurs after 6 months, we are going to call it chronic rejection. For chronic, again, it is relatively easier to comprehend because it would be a delayed manifestation, so type 4 hypersensitivity, which leaves us with, I think I've given you sufficient time to think here. What is the type of hypersensitivity which should be answered for acute rejection of the kidney? Then the answer should be given as type 4 hypersensitivity. On this, there's a possibility that you might say, sir, in micro we have been taught type 3, so I don't dispute that. In most of the books, in medicine books, he mentions type 4 hypersensitivity. In some micro books, he mentions type 3. So my suggestion to you would be that I would like you to remember this number 244. 2 and 4 are easier to comprehend. It is just the one in the middle which looks a little non-palatable initially. Acute word, it looks like how can it be type 4, but that's how the textbook says it. So 244 can be remembered for the types of rejection that can be seen, and our main objective is to prevent the development of this acute and chronic rejection by the usage of STM, that is steroids, tacrolimus and mycophenolate, with additional support of azathioprine, and we can prevent this rejection from occurring in the person. But in spite of this, we have a price to pay, that is post transplantation there could be infections developing in a patient. So we will now make a list of what are the important opportunistic infections that could be seen due to anti-rejection drugs being used in the patient. Your answer will depend upon whether the person has developed this within the very first month after a kidney transplantation, is it 1 to 6 months, or after 6 months. If a person is having within the first month itself, then it's going to be mainly Staph aureus, and this would be a surgical site infection, and this hospital needs to have a serious rethink of its infection policy, because when you are undergoing such a dicey and expensive procedure and the hospital infection control policy is not working, then person can develop a surgical site infection with Staphylococcus aureus, and sometimes even Staph aureus infection can cause a pneumonia as well. So this hospital needs to seriously reevaluate and look at whatever the flaws are present in the infection control policy of the hospital. And after Staph aureus, then there could be a virus also. Don't answer cytomegalovirus at the moment. I told you, cytomegalovirus is the commonest cause of graft failure after a solid organ transplantation. But at the moment, your answer would be a herpes reactivation, which would be in the form of herpes zoster. But if he mentions what infections can occur between 1 to 6 months after kidney transplantation, then the first answer of yours would be a pneumonia. You read about this organism even with HIV patients having a CD4 count of less than 200, so pneumocystis jirovecii. And if he himself says viral infection, then your answer is okay, that would be cytomegalovirus. And he can also give you a slide of renal tubular cells. And in the renal tubular cells, what you will find is that the nucleus and the cytoplasm both will be having basophilic inclusions. What I'm saying is cytomegalovirus per se results in intranuclear as well as intracytoplasmic basophilic inclusions. Why I'm mentioning this is because the question was deliberately made a little clinical with the image. He said a person has undergone a kidney transplantation, but post kidney transplantation the kidney function is not picking up, rather the kidney function is deteriorating, and the doctor was worried about the chances of a graft failure, so he got a urine microscopic examination done. In the urine microscopic examination, the student of mine described, though you don't need to draw this, is that was in the nucleus as well as in the cytoplasm. What he could see was that classical, what you study as owl eye appearance. So traditionally you read about owl eye appearance with a lymph node biopsy for Hodgkin's lymphoma, but what this was actually a FMG exam question, so relatively an easier one. Owl eye appearance was described or was shown, but this was for renal tubular cells, and most chaps they were easily able to pick it up that it is both a blue intranuclear basophilic as well as a intracytoplasmic inclusion. So it was an indirect kind of a question, like the answer is straightforward. Cytomegalovirus commonly complicates is responsible for graft failure after solid organ transplantation, but he gave it in the form of an image and gave a long history describing that graft function is not like it was initially present, and what could be the possible explanation for it with the Aulai appearance that is shown. Apart from cytomegalovirus, you need to remember regarding hepatitis B as well as hepatitis C. Now let us focus on what would you answer in case in the exam he mentions for organism which would be beyond 6 months of age. So what I'll do is describe for after 6 months of age with respect to solid organ transplantation. The first answer of yours would be a fungal infection. Yes guys, follow this table that I'm telling you, that after 6 months your first answer is a fungal infection, that is Aspergillus, and it could be a bacterial infection, that is Nocardia. And after this would come the name of the virus, and this time the name of the virus that he'll be interested to hear from you would be polyoma virus. The polyoma virus that we are talking about at the moment is BK virus. Traditionally, the polyoma virus that we study is JC virus. No, with natalizumab in pharma, you would have studied. Natalizumab is used in multiple sclerosis. With natalizumab, there can be a JC virus reactivation, which is called as progressive multifocal leukoencephalopathy. The word is JC virus, but the virus that I'm talking about at the moment is BK virus. So from the exam perspective, the viruses which are to be remembered by you would be herpes for the initial part, herpes reactivation, cytomegalovirus for 1 to 6 months, and then after 6 months would be BK virus. And there have been questions where he has been very specific and very precise. I'll just highlight this fact once again. If he says what is the most common cause for development of graft failure after either a solid organ transplantation or a hematopoietic stem cell transplantation, then the number one answer would be given as cytomegalovirus, where a Aula appearance would be present. Now look at the way he will twist the MCQ. The question said, which of the following is responsible for post-transplantation lymphoma? The question was not asking regarding graft failure. He said post-transplantation lymphoma is seen with, so you know the very well fact that lymphomas would be associated with Epstein-Barr virus. And then he has also asked another peculiar question. He mentioned that the person is on maintenance therapy after kidney transplantation. He even mentioned the name of the drugs. And he said, any patient after kidney transplantation who is on maintenance therapy, what cancer can develop in these patients? The student of mine who attempted this question, he said, sir, initially while I was reading the question, kidney transplantation was described beautifully, maintenance therapy. So I thought he'll ask about opportunistic infection that you discussed. And the question said, due to this maintenance therapy, which cancer can develop in these patients? And this is a rare fact, but then has been asked in the exam. So it's my job to tell you that people who have undergone kidney transplantation and are taking anti-rejection drugs, they have a high incidence of development of skin cancer. Yes, guys, skin cancer risk is increased disproportionately in patients on anti-rejection drugs. So you can see the disadvantage. I mean, I was talking about kidney transplantation being preferred, but at the same time, I mean, you can't win everything, right? Whenever you fight a war, there will be some gains and some losses. So the gain here is that quality of life is improved in the person. He doesn't need to go to the hospital again and again for hemodialysis. The loss that is occurring here is that the person on the long run may, I'm not saying a guarantee, but may end up with development of skin cancer as well. So especially with respect to kidney transplantation, you need to remember at least the minimum aspects I expect you to remember would be one, the types of hypersensitivity reaction and the opportunistic infections, especially from the virus perspective with respect to the various time zones or time categories that I have mentioned. Whenever we read the term hemodialysis, you'll always encounter this word extracorporeal. So first we'll focus on what we mean by the word extracorporeal. Extracorporeal simply means that there is a membrane outside the body, and this membrane, the semi-permeable membrane, is allowing a solute exchange. You see in these patients, the bad guys, the urea, creatinine, potassium is elevated. So the holes in the filter or the holes in the dialyzer are designed in such a fashion that the bad guys are lost. But the good things like proteins, we don't need to lose proteins, we don't need to lose glucose, we don't need to lose RBCs. So the good guys will stay back, but the bad things would be moving across this semi-permeable membrane. So I'll also mention from physics perspective that what is the principle of hemodialysis, but we are using a semi-permeable membrane outside the body. The technical word that is used for the filter that is present in the hemodialysis machine would be that this would be a hollow fiber dialyzer. And along with this also written is the word biocompatible. What he means by biocompatible is that in the earlier times, this dialyzer filter that I'm talking about that was available was cellulose based. And the problem with this cellulose based filter slash dialyzer was that it used to activate the complement system, and due to activation of the complement system, allergic reactions or anaphylactoid reactions were relatively more common. I'll repeat this once again. I said in earlier times, the filter, that's the casual word, or the technical word is dialyzer. So that was because it was cellulose based. So activation of the complement pathway used to result in more allergic reactions that used to develop in a patient, increased risk, I can say, of anaphylactoid reactions. But currently, the one material that we're using is biocompatible. I did not say anaphylaxis, I said anaphylactoid reactions incidence was higher during hemodialysis. Now it is relatively lesser because we're using is a hollow fiber dialyzer, biocompatible. This would work like capillary tubes. I mean, the filter, I'm saying a filter, but it's actually the capillary tubes in which there are holes present from which the bad solutes can be lost and the ones that we want to retain can be retained. Now let's look at the vascular access. I mean, every time we are going to talk about hemodialysis, we need to take a vascular access in a patient. So the preferred way to get a vascular access would be to create a fistula. What I mean by the fistula is that the surgeon's help would be required in this case to connect the radial artery of the patient to the cephalic vein. You see, in the honor of the individual who described this procedure initially so that we could do was an effective hemodialysis, I'm just mentioning the name here, that is Brescia Semino fistula. In the exam, he may not actually ask you the name of Brescia Semino fistula, but he might just ask you that this fistula is creation of anastomosis between which blood vessels. So your answer would be this is connection between the radial artery and the cephalic vein. I'll just move my slide to show you the diagram part of this also. I mean, what we are simply doing is creating a fistula between the radial artery and the cephalic vein. And the question that will come in your mind would be that why are we doing it? I mean, could we not have simply put a catheter, a double lumen catheter in the vein and start doing a dialysis? I mean, with the help of double lumen catheter, we can remove the blood and then we can push back the clean blood back into the body. Yeah, we could have done that, but you see, the problem with veins is that they can collapse very fast, and more importantly, there is a high chance of development of thrombophlebitis. So what you're doing here is when you connect the artery to the vein, the high pressure blood of the artery will be going in the vein, and what this will do is it will change the internal lining of the vein. What I am trying to do, guys, here is by connecting the artery to the vein, I am changing the behavior of the vein in a sense that I'm doing arterialization of the vein. Now the advantage of doing this arterialization, it means internal lining of the vein will change. The advantage of this is that the chances of development of thrombophlebitis, all of you as interns could be putting cannulas on a regular basis. So many cannulas you have to put in every day that you become expert by this time. And you notice the fact that even when you're giving IV fluids to somebody, antibiotics to somebody, thrombophlebitis occurs after a few days, you have to change the cannula site. Here I'm saying if you try to, do dialysis from a peripheral vein, then thrombophlebitis will start occurring, and gradually the hemodialysis has to be done 3 times per week, and long duration. So all the veins will ultimately get affected and there would be no vascular access available. So I am creating a site from where hemodialysis can be done. I'm training that site to take pressure, because you see, when we do dialysis, we remove blood from the body, we send black blood into the body. So because with pressure we are sending blood back into the body via the vein, we need the vein to get adjusted to high pressure. So, right, if I connect the artery to the vein, I am training the vein. You need to get rough and tough so that you can take the pressure during the process of hemodialysis. And therefore, arterialization of the vein has been documented to reduce the incidence of thrombophlebitis. Plus, it will generate a pressure head also. By pressure head, I mean artery pressure is always more than the vein. So when we cannulate for hemodialysis, then because the systemic pressure will cause the blood to flow towards the machine, and the clean blood can be sent back via the venous circuit into the body of the patient. It takes a while for the harvesting of this fistula. What I mean by the harvesting of the fistula is that if you do create a fistula right now, it's not that the fistula will start working immediately. We need to give some time for the healing of the fistula so that subsequently we can start doing hemodialysis, and the time period for the harvesting can be weeks. This is the reason why I was saying that in G4 itself, we should start planning either a transplantation or a hemodialysis, because in hemodialysis, the excess that we make, it's not that from the site of where you have created the fistula you can start doing hemodialysis from tomorrow itself. You need some time for the harvesting of the fistula. When I'm saying harvesting of the fistula, then I'm also pointing to the fact that how would you know that now this site is ready for performing hemodialysis? There would be a bruit, because when you create a proper vascular anastomosis, it will create a bruit, and this bruit can be either I can say auscultated, or I can just say this casual word that if you put your hand over this fistula, the feeling that you will get will be like the purring of a cat. So, I mean, to a non-medical person, I'll say like when you put your finger over the site where the fistula is present, I'll use the non-dominant hand in the person, then it would be felt like purring of a cat, or you can hear a bruit. And I will also be using a Doppler. I mean, the Doppler will help me determine that, okay, in this particular case, I'll be able to document that the vascular anastomosis has worked properly. First approach is always to create a fistula. Now, suppose I'm saying, hypothetically speaking, if fistula is not possible to be created due to anatomical reasons, then we can connect the artery to the vein with help of a vascular graft. Also, I'm talking about the artificial blood vessel, and this artificial blood vessel can be used. Let me just represent it diagrammatically here. Let me say this is the radial artery of the patient, and in blue I've shown is the cephalic vein. So we can connect the two with help of PTFE. This is an artificial blood vessel. This is an artificial blood vessel which we can use here to connect the artery to the vein and achieve the same thing. So ideally says, I mean, the approach is fistula first. We should ideally try to ensure a fistula formation. If not, then the second approach for us would be that we can be putting a AV graft. The material of this AV graft would be PTFE, that is polytetrafluoroethylene. I mean, that could itself be a question, and you know that from your general surgery itself. And once I have taken the access in the patient, the vascular access in the patient, now this patient would be ready for dialysis, and let's just practice what would be the principles of hemodialysis. Now, the principle number one of hemodialysis would be that there is a solute diffusion across a semi-permeable membrane. Easy to understand because any solute can diffuse from higher concentration to a lower concentration, but then the problem is all solutes are not in dissolved format. Only an undiluted solute can travel by diffusion process. If the solute is diluted in fluid, then it will not be able to diffuse easily. So there's a second principle also that is called as solvent drag. What I mean by solvent drag here is that the fluid is having dissolved solutes, because in patients who are having renal failure, there would be approximately about 50 types of toxins present in the body. It's not only about urea creatinine. There are many other toxins present in the body that need to be removed out with help of this hollow dialyzer membrane. So the second principle is solvent drag, and the solvent drag is also written as ultrafiltration. This is for those products which are dissolved in the plasma. I mean, for point number one, I was saying for like routine solutes which can easily diffuse across a membrane gradient. But ultrafiltration or solvent drag would mean that solutes which are dissolved also are getting lost. And in hemodialysis, we also try to replicate nature by using countercurrent mechanism. What I mean by countercurrent mechanism is that the flow of blood in the dialyzer machine and the flow of the dialysate fluid will be opposite. You see, there's a dialysate fluid that is being used and the blood of the patient, then both are not going in the same direction. We tend to ensure that the blood of the patient in the dialyzer machine versus dialysis machine versus the dialysate fluid, they move in opposite direction, because this countercurrent mechanism helps in creating a gradient, and this causes a better solute exchange. I repeat once again, like in our kidney, we read about vasa recta. We read about the fact that the flow of blood around our kidney tubules. I'll just replicate what you study in physiology. If this is the kidney tubules, then we have blood vessels surrounding it. So we always study in physiology, and I'm just replicating that the flow of blood in the blood vessels, that is vasa recta, will be opposite to that of the ultrafiltrate, and this would again facilitate the solute exchange. So there are two principles which are to be answered. That is going to be solvent drag, that is ultrafiltration for dissolved products, and solute diffusion. If single best answer is asked, then your answer would be given as solute diffusion. And to facilitate this solute exchange, we also tend to use physiology, that is the dialysate fluid and the ultrafiltrate or the blood of the patient in fact are moving in opposite direction. In this diagram, I've shown that graft, the PTFE graft that I was talking about, that would be connecting the radial artery and the cephalic vein of the patient. And in case, on one side, the radial artery and the cephalic vein, suppose the harvesting of the fistula is not successful and even the graft part is not successful, on that particular side, I can use the contralateral side, or we can use the brachial artery and the basilic vein in the patient. So there are multiple sites which we can be using. Groin would not be recommended, femoral artery, femoral vein, because of the issues with respect to hygiene, but peripheral extremities and distal veins are the ones which are recommended. We don't recommend subclavian artery and subclavian vein, because if you are gonna use or try to create a fistula with respect to central veins, and suppose the entire circuit undergoes a thrombosis, then the distal veins will be useless. If the central veins undergo thrombosis, then the distal sites cannot be used. So he says it is the distal peripheral sites in the upper extremities that would be preferred for doing hemodialysis in the patient. We have a roller pump that generates pressure. I mean, that circular motion that is occurring, that's a roller pump. It ensures that the blood is removed out. The unclean blood or the impure blood will flow into the dialysis machine. As you can see, that's the dialyzer. So the blood is moving in one direction and the dialyzer fluid is moved in opposite direction. That's the counter current mechanism, and the end result is that we get clean blood which will be pumped back into the body. We will also need to anticoagulant, so heparin will be used in the circuit also, because otherwise there is a high probability that the blood can clot while the process of dialysis is being done. And now it is important for us, once we have understood regarding what are the sites from where we do the hemodialysis, I mean what are the vascular accesses that we'll be obtaining, what is the principle, our next objective would be to study regarding what are the indications for doing hemodialysis. Here I'll incorporate a general, I mean this table is not only for CKD but is also for acute kidney injury, because lots of time there could be acute kidney injury superimposed on chronic kidney disease, because these patients have a decreased renal reserve. So we are next going to discuss regarding what are the indications of doing hemodialysis in a patient, and the mnemonic that we can use for this is AEIOU, the standard one. So let's look at A. If a person with renal damage is having a metabolic acidosis, a high anion gap AGMA, high anion gap metabolic acidosis, the pH of the patient is less than 7.1 in spite of medication. You see, I'm writing here, he is refractory. You have given soda bicarbonate to the patient, but in spite of our best efforts, medical therapy has been instituted and still the person is having metabolic acidosis. We would like to plan hemodialysis in a person. Similarly, alphabet E is for not encephalopathy. Your answer here would be electrolyte imbalance. The electrolyte imbalance I'm talking about is once again hyperkalemia. Please remember, this slide is a general slide for indications for hemodialysis in both CKD, AKI, and then AKI superimposed on chronic kidney disease in a person. So hyperkalemia, which is again refractory to medical therapy, I am going to be interested in ensuring that we get rid of the potassium, because it can cause cardiac conduction disturbances. It can cause a cardiac arrest in a patient. Alphabet I would stand for renal insufficiency. With respect to renal insufficiency, there are different guidelines. Like some books say that estimated GFR of a patient, if it is less than 10 ml per minute, that is when hemodialysis should be instituted. On the other hand, I mean, some like the Canadian guidelines are estimated GFR of the patient less than 6 ml per minute. Only then, I mean, they are doing a delayed dialysis. What they're saying is if you try to do early dialysis in a patient, then there's a probability that the cardiovascular complications can be higher. Extracted atherosclerosis can be higher. So he says that we should try and delay, though there's a controversy about it. So let the experts and SS people handle it. At the moment, the points are that if the eGFR of the patient goes even lesser than what I explained to you, I told you less than 15 complications are occurring. But I mean, in all patients, complications would not occur at 15. In some, they are saying take the cutoff as not 15, but take the cutoff as 10. So I have mentioned American and the Canadian guidelines here before you, in which they have deliberately delayed the institution of hemodialysis in a patient. First thought process of ours is we should try and institute an early hemodialysis. He says early should be transplantation. He says if you want to be in a rush, do a transplantation. When it comes to hemodialysis, the current thought process is try to delay it, because the complications of hemodialysis will also be having impact on the cardiovascular health status of the patient. Coming to alphabet O, that's easy to comprehend. If a person is having volume overloading, this volume overloading would imply not that he's having a pedal edema. I'm not worried about that. But if there's a volume overload of fluids and that is causing even a pulmonary edema, which is refractory to medical therapy. Alphabet R here means that we have already refractoriness to drugs has been documented. Then in overload situation, I will be in a hypervolemic hyponatremia. It's not for the hyponatremia component, it's the hypervolemia that will cause hypertension. It's the hypervolemia which will cause more damage, because if you have hypervolemia, it can cause more damage to the basement membrane of the kidney. The filtration barrier will be is impacted by high blood pressure. So it's important that you try to control the blood pressure with ACE inhibitors in these patients initially, or with CCBs, or with alpha blockers, or even add beta blockers if cardiovascular problem is there. But he says that in the end, in spite of everything, if there's a high blood pressure, there is a left ventricular failure occurring in a person, there's a pulmonary edema, there's a volume expansion, you need to go for hemodialysis in the person. Then alphabet U would stand for uremic complications. The uremic complication to be remembered are multiple. Person could be having uremic pericarditis. Urea can cross the blood-brain barrier, so there can be asterixis and myoclonus developing in these patients. Subsequently, that is uremic encephalopathy. Out of all of these, though all of these are indications for doing a hemodialysis, if he asks you to select one, if he asks you to select one, and he says which of the following should be answered as an absolute indication for hemodialysis, then your first answer should be given as uremic pericarditis. Why that is so is because, again, the query in your mind would be, sir, something like uremic pericarditis. You see, patients of CKD tend to have an increased, or CKD or AKI, both are having increased risk of bleeding. If somebody is having uremic pericarditis, he says that because these patients are having a pericarditis and they're also having an increased risk of bleeding, they could be bleeding in the pericardial space. Repeat once again. He's having a pericardial friction rub, pericarditis present due to toxin induced damage to the heart. In these patients, there is also increased risk of bleeding. When you combine the two, there can be bleeding in the pericardial space, and this bleed can be so extensive it can cause a cardiac tamponade and expiry of the patient. So it is not that other indications are, I am trying to, negate them. Yes, they are also indications for dialysis, but in a worst case scenario, the first answer of yours would be given as uremic pericarditis. What I'm telling you next has already been discussed by me verbally, but I'd like to reiterate those statements once again. If a question says what is going to be the most common acute complication of hemodialysis, then your answer would be given as hypotension. But if I change this question, look at the wordings now. He says, what is the most common complication of recurrent hemodialysis? Then your answer would be given as accelerated atherosclerosis, which is why I was explaining to you that hemodialysis is not an ideal. I mean, yep, for the person's survival, we are using it, but it's not an ideal solution per se. Other complications that I would like to mention and are asked in the exam are dialysis dementia. Why this MCQ is asked is because in dialysis dementia, the component which contributes to dementia is A beta 2 amyloid, and you can see the reason while I'm writing it, because in Alzheimer's disease, I'll just use a alternative color to say that. I hope you recall, in Alzheimer's we have studied regarding A beta amyloid deposition that contributes to senile dementia, but in dialysis dementia it is A beta 2 amyloid. This A beta 2 amyloid is also documented to get deposited in the carpal tunnel. So he could mention a CKD patient having pain in the wrist and pain in the hand. That could be carpal tunnel syndrome with features of median nerve involvement like ape thumb could be described. Other ones that I'm writing are only for the sake of completion, like they could be complication like dialysis disequilibrium. You see, when you do dialysis in a patient, it has to be for a particular duration and at a particular frequency. When we do very frequent dialysis in a person, it can cause fluid shifts across the brain, and this fluid shifts across the brain can cause a cerebral edema as well. So the term used is dialysis disequilibrium, which occurs because of fluctuations of the plasma osmolality. I repeat once again, if I would say too frequent dialysis in a patient is done, then the fluctuations of the plasma osmolality can cause fluid shifts across the brain. And then he also mentions that when you are doing a hemodialysis, then across this filter, vitamins can be lost. So these patients can develop a peripheral neuropathy. This disease per se is a catabolic process. So muscle wasting will be occurring. And in these patients, if GFR is less and there is a muscle wasting component present, then in these patients, if dialysis has not been started, the protein intake would be about 0.8 to 1 gram per day. But in a person in whom hemodialysis has been initiated, then protein intake has to be increased. So remember that fact from the nutrition perspective, though that's very generalized kind of a concept, so I'm not writing it, that proteins in CKD patients on hemodialysis has to be higher than what is the normal requirement in you and me is 1 gram. Textbook says 1 to 1.5 grams in persons undergoing hemodialysis. But if a person is in G1, G2, G3, is not undergoing a hemodialysis at the moment, then the amount of protein intake would be 0.8 to 1 grams. So these are the details that I would like you to remember for this topic. It took a while to cover, but then the grading part that I've described, A, B, C, D, E mnemonic. I spoke multiple mnemonics here, A, E, I, O, U, A, B, C, D, E. So initially, I mean, you are bombarded with large number of mnemonic, but the minimum I expect you to remember is the treatment part. HbA1c control, blood pressure control, cholesterol part, vitamin D aspects, then erythropoietin and chronic hyperkalemia management are the minimal aspects which you are expected to remember for this topic. And thank you for your patience for hearing me out.